Assalamu alaikum. We will start our today's session with patient name Mr. Ahmed, 28 years, came with complaint of difficulty walking. I will share the timer, then you can start.
Okay. Okay. Hello.
Hello.
Hi. Good evening. This is Dr. Turkawi, and I'm one of the doctors in the clinic today. Am I speaking to Mr. Ahmed?
Yes.
Hi, Mr. Ahmed. I understand that you came with difficulty in walking. Can you tell me more about it, please?
Yes, doctor. Actually, yesterday I woke up from the sleep, has difficulty in walking and very weak, weak sensation, very weak in weakness in my in both legs, Doctor Ahmed. Doctor.
And when did that start? You said yesterday, right?
Yes, it is started yesterday at the morning,
Mm.
and it
Have you?
resolved spontaneously after 4 hours, about 4 hours.
Okay. Do you think you did anything that made it better, or it was on its own?
It, spontaneously.
Okay. And was it gradual or sudden onset?
Actually, when I wake up from the sleep, it was suddenly yeah, it was very weak, and I don't know why this weakness, doctor.
Okay. Did you
And
have it
after,
before?
actually, this is the third time for me to have it.
Okay. And you were saying something.
What? I'm sorry.
Excuse excuse me. Were you saying something?
No,
Okay,
I
so
said
so you had
third
it
time.
3 times. When was the 3 times? When were they?
During the last 3 months,
Mm.
I have these three. I have seen these 3 times. The last
Okay.
one it was yesterday.
And the 3 times it lasted for 4 hours?
About 4 hours, 3 hours. Sometimes it lasted even for 6 hours.
Mm. Okay. And when you say weakness, when you say difficulty walking, is it like you feel completely paralyzed and unable to walk, or you feel a little bit weak?
No, I completely paralyzed, doctor. It was
Okay.
very floppy.
And do you have weakness in the hands as well, or is it just the legs?
Once from this 3 times, and I was also on my hands and arms.
Okay.
But usually it
What
comes
about
in my legs.
and is it does it happen in the evening towards the end of the day or
No, every time it occurred to me in the morning.
in the morning? Okay. And did you have any swallowing issues with it?
No, no,
Any breathing problems?
no,
Okay. Any back pain with it?
no, doctor. No, no back
Any
pain.
have you had any trauma?
No,
Any sensation problems with it in your legs or
no,
your hands?
no, no,
No. Okay. And any shakiness
no,
in your hands?
no,
Any awareness of your heartbeats?
no,
No. Any weight loss with it?
no, doctor. I have no weight loss.
Any fever?
No,
Okay. And have you been noticing any lumps or bumps anywhere in your body?
no, doctor.
Okay. And did you notice that maybe eating something might make it better or worse? Like banana, for example.
I'm not sure, doctor.
Okay. Did you have any loose motion with any of these attacks or before them?
No,
Okay. And any chest pain?
no,
Okay. And did you notice that your face is different in change? Any side of your face that looks different than the other side?
no, no,
Face droop?
What?
Any facial droop or drop?
No, no.
Okay. And what about your diet? Is it
Normal
healthy
diet.
diet, balanced diet, or are you vegetarian?
Yes. Yes, balanced diet.
Okay, so you eat meat and everything.
Yes, I ate everything.
Okay, and what about any abdominal pain?
No,
Anyone told you that you look yellow or pale?
no,
Okay, and do you have any medical condition, Mr. Ahmed?
no, doctor.
No. Do you have anyone in the family who have the same condition?
Actually, I'm adopted, doctor.
You're adopted. You're not known to have any medical condition, right? You didn't
Yes.
have any surgery.
No,
No, okay. And are you on any medications, Mr. Ahmed?
no,
Any over-the-counter medications?
no, doctor.
Any recreational drugs?
No,
Any intravenous? This might be a little bit sensitive question. Any injectable drugs?
no, doctor.
What about alcohol?
Occasionally, doctor.
Occasionally. And how much is occasionally?
In the weekend only.
I'm sorry?
In the weekend only.
How many units?
About 10, 8 to 10.
Okay. What about your job, Mr. Ahmed?
I am a teacher, doctor.
Your teacher. And is this affecting your job?
Yes, doctor. Actually, in this the day which I have this weakness, I can't go to the work.
Mm.
I can't move from bed. Actually,
Okay, okay. Any preference, weather preference, Mr. Ahmed?
no.
All right, we will try to sort out the job concern. Would that be okay?
Okay,
Later. I would like to examine you, and while I'm examining you, I might ask you a few questions. Would that be all right?
okay.
Okay, so looking at the patient, exposing the lower limbs, any wasting,
No,
any walking aid?
no, no,
Okay. Any fasciculation or scars in the legs?
no,
Okay. Tone,
normal,
power in both limbs,
normal,
normal, and reflexes.
no,
Okay. And sensation are intact, right? He never had any issue with
yes,
sensation. So
yes,
reflexes, I'm gonna do the Babinski and everything. Looking at the back, any scars?
no,
No. And any tenderness?
no,
Okay. And spreading, can you spread your fingers and just lift your arm up? Any tremors?
no, no famous.
No tremors. Okay. Have you traveled recently, Mr. Ahmed?
No,
No. Okay. And looking for checking so in the hands, any nicotine tar, any pallor or cyanosis, any
no,
nycolicia,
no.
pulse
80%, 80 normal, equal.
80 and normal.
Yes,
Okay.
mm,
Any collapsing pulse,
no,
proximal myopathy.
no,
Do
normal,
you find
no.
difficulty standing up from a sitting position, Mr. Ahmed?
Actually, doctor, during the attack, I have very weakness. I can't go, I can't stand. Oh,
But
but
usually between,
between attack, I am normal. I don't have anything. Didn't have anything.
okay, okay. And looking at the patient eyes for pallor and jaundice.
No, no jaundice, normal.
Okay. And
Mm,
the face
normal
tone.
face.
Okay. Have you had any skin rash, Mr. Ahmed?
No,
Any joint pain?
no,
Any tiredness between attacks even?
No, doctor. Other than
No?
these attacks, I'm normal. Quite
Okay.
well.
Okay. And what about water work? Is it normal?
Yes, doctor.
And no vision problems as well?
No vision
Oh,
problem.
okay. Lymph nodes in the neck normal?
Normal, Nicole. No swelling.
And listening to the heart epic beat?
Normal.
Okay. And hepatosplenomegaly?
No, it's really good.
No organomegaly. Okay. So, Mr. Ahmed, you are adopted and you don't have any family record. Have you ever had any
No,
hospital admission for any reason for yourself?
no, doctor.
And who do you live with, Mr. Ahmed?
Uh, my now I live with my friends
With
as I
your
am
friends?
working. Yes.
Okay. Do you have partners?
Uh, no,
Do you have any casual, this might also be a sensitive question, any casual sexual partners?
no.
No, okay. Uh, I'm sorry? No, okay. And when you have these attacks, who help you
My
with
friend.
your friends? And
Yes.
do you feel that you are well supported by them?
Yes, doctor. We are support each other.
Okay, all right. And before these 3 months, have you had any attacks before?
No, I can't remember actually, but no,
You had no
I
attacks before and no other
no.
medical condition at all?
Yes, yes.
Okay. So,
Okay.
Mr. Ahmed, what is your concern?
Yes. Yes, doctor.
What's your concerns?
What's the problem with me, doctor? Why this attack come to me?
Okay, that's a very valid concern. Um, so I understand that you have so just to gather what to make sure that I got it right. You work as a teacher. You have a very normal diet. You don't have any hand shakiness or any weather preference, like preferring cold weather. You don't have any loose
Mm,
motions or neck swelling, do you?
mm,
And no
yes,
vision problems at all.
yes,
You have these attacks that has been happening 3 times over the last 3 months, where you have weakness for a few hours and then it resolves uh, spontaneously on its own.
yes, doctor.
No, is there any loss of consciousness associated with it?
No, doctor. I didn't have
Anything that
any loss
makes,
of consciousness.
I'm sorry?
I didn't have any loss of consciousness, doctor.
And you okay. And and you are also you worried about the diagnosis and you're also worried about your job. So I understand that we will need obviously to admit you and to we might not need to admit you, sorry, because you don't have any weakness at the moment. We will need to investigate you, take some blood samples to confirm the diagnosis, which is called probably the periodic paralysis. Don't bother with the name. It's a condition in which that you have periods of weakness that can happen to your legs and hands. The reason is usually related to either a thyroid problem, which is a gland in your neck, or sometimes also the potassium level problem. At the moment, it will be difficult for me to tell without doing blood tests and scans and referring you to the gland doctor, having a team of medical people to treat you. I will give you some spreadsheets, some sheets about the condition, and I can give you a sick note explaining your condition to the occupational health in the school that you work at. Would that be okay?
Okay, doctor. Thank you.
Okay.
Okay.
Once you have the weakness, you can always let the occupational health in your school know, and they will do the needful. Um,
And you will do it?
and they will do the paperwork for you. You don't worry about work. Regarding this condition, it might be something that you got from your blood family, which is also can be something that you can pass to your kids in the future. Are you planning to have any children?
Yes, doctor. Actually, I want to be married and I want to marry and I want to have children. Is a
Okay.
familial condition?
I'm sorry.
Yeah, time is up.
Okay.
Okay. What's your
Okay,
differential?
let's go to the examiner. Yes, please.
Okay, so my differential would be either thyroid periodic paralysis or uh, hypokalemic periodic paralysis. As this 28 years old gentleman coming with periodic paralysis that spontaneously resolved, I could not locate the symptoms to either of the two differentials. So we will need to investigate more.
What else other than periodic and thyroid?
I'm sorry?
Other than thyroid and thyroid paralysis and the hypokalemic.
Other than the thyroid and the hypokalemic, it can be familial, and it can also be vitamin B12 deficiency or alcohol-related weakness. However, as I mentioned, I could not appreciate any diet imbalance or alcohol excess.
Okay. What's your investigation?
So I would start by doing the baseline bloods, which are full blood count, looking for any macrocytic anemia or any high infection markers. Renal function test, urine function test, renal and electrolytes, looking for potassium level, and liver function test as well, looking for the albumin levels. I also need the thyroid function test and plus or minus, and thyroid stimulating hormone, including the thyroid stimulating hormone T3 and T4. I would also need having an MRI to his back, which might be the latest, the last
Why
investigation that I
MRI?
might need to do.
What do you expect to see in MRI?
If the patient came to me during the attack, I might need to see if there is any intermittent inflammation in the spine.
Okay.
It can also be multiple sclerosis. However, so that's why I will need the MRI as well.
Okay. How you treat?
How would I treat? So, so there is enough pharmacological part to educate the patient about his condition and about the provoking and exacerbating factors. Social support involve the GP and the community nurse in the process. He will need physiotherapy during the attacks, and also occupational therapy. The patient also might need some psychological support and genetic counseling as he is planning to have children. He would also need to be educated about the food supply if it was hypokalemic, periodic paralysis. He might need endocrinology consultant referral because he might need some thyroid medications if there is any subclinical hyper or hypothyroidism.
If this
And yeah.
patient is hypokalemic periodic paralysis, what will you give him during the attack?
What will I do for him?
Mm.
Correct the hypokalemia and advise the patient of high potassium diet, especially during the attacks.
Okay. You will give him IV, potassium, or oral.
That's a difficult question. I have no idea, but if the potassium is very low, I will give him IV potassium, IV KCl, 40 millimoles. But I don't really
In
know.
between attack. Okay, in between attack, what will you give him?
I'm
In
sorry?
between attack, what will you? In between attack, you will give him what?
I don't know specifically what should I give him, but I think maybe high potassium diet. But I really don't know the answer. If it's hypokalemic.
Thank you. الوقت بيخلص. الحمد لله، جزاك الله خير، عملتي كويس جدا. So did very well.
Okay, one more question because still 30 seconds. Dr. Sarah, Dr. Shema, sorry, I will ask her
Okay,
question.
if
You can
this
ask her,
patient
yes.
has hypokalemic attack, you will do ECG, yes?
Yes, yeah, definitely. If he had
What is the
the
features? What is the features of hypokalemia in ECG?
I would find the flat T wave, maybe arrhythmia, prolonged QTC.
What else?
Hmm.
Okay, خلاص كده الوقت خلص، صح كده؟
خلاص.
Yeah, time is up. Actually, Dr. Shema asked my question. Supposed to ask Dr. Renas. You asked the same question. Okay, and now comment from Dr. Shema, and then we will comment.
Okay. ما شاء الله عليك يا ريمان، ربنا يحفظك يعني. you did very well. بس بسرعة كده هقول حاجات يعني بسرعة. أولا هي زي ما أنت قلتي بالظبط، هي في الغالب بتبقى هايبوكاليميك بريودك باراليسيس. هي دي اللي بتيجي في الامتحان يعني في الغالب.
مم.
بس في سؤالين كنت المفروض تسأليهم، اللي هم إيه اللي كنت بتعمله في الليلة اللي قبلها،
مم.
لاست نايت. لأن إحنا دايما بنربطها بالهيفي اكسرسايز وهيفي كربوهيدرات ميل. What you did
Heavy
before the
carbohydrate meal make it worse.
yes and
Oh,
heavy exercise.
okay.
حتى كان في قصة دايما ان انا خرجت العب مع اصحابي واحنا اتعشينا بعد كده.
مم.
خلاص. فبريسيد باي هيفي ميل او هيفي اكسرسايز، دي التريجرنج بتاعها. الديفرنشال دايجنوز بتاعنا زي ما انت قلتي بالظبط، ثيرويد بيريودك باراليسيس، هايبوكاليميك وفي هايبر كاليميك وفي كونفرجنت ديس اوردر. يعني المود وكده كان المفروض نسال عن المود برضه والستريس،
مم.
عشان من ضمن الديفرنشال بتاعها
Hypokalemic and
كونفرجنت.
hyperkalemic.
هايبوكاليميك وهايبر كاليميك وثايروتوكسيك كونفرجنت ديس اوردر. اوكي.
مم.
الاكزامينشن انت عملتيه كويس، عملتي كل حاجه تقريبا، بس هو المفروض بنعمل سي ان اس وكارديو فاسكولار يعني.
مم.
بالنسبه للانفستيجيشن، البيزك انفستيجيشن زي ما انت قلتي، وبنعمل البوتاسيوم ليفل ده ديورنج الاتاك. هو ديورنج الاتاك بيبقى قليل، ديكريز ديورنج الاتاك، لكن ايه ممكن ما يبقاش بلون نورمال، يعني حتى يكون لو، بس لو نورمال برضه ممكن يبقى ساعات لو نورمال.
مم. مم.
وبنعمل كرياتينين فوسفوكاينيز، ده اللي بيزيد ديورنج الاتاك. وبنعمل بوتاسيوم على الكرياتين ريشيو عشان نعرف البوتاسيوم ده سكندري ولا برايمري.
I'm
بوتاسيوم على
sorry, say that
الكرياتين
again. So أول حاجة بعملها شنو؟
بوتاسيوم
ال-
ليفل during الاتاك. طبعا البيزك انفستيجيشن دي
أيوه.
واحد. تاني حاجه
مم.
البوتاسيوم ليفل during الاتاك بيقل،
مم.
بيبقى ممكن ما يبقاش maybe not less than normal، ممكن يكون بس
مم.
low normal.
مم.
تاني حاجه كرياتينين فوسفوكاينيز، ده increase during الاتاك.
كرياتينين فوسفوكاينيز.
ايوه.
اوكي.
بعدين عندي حاجه اسمها بوتاسيوم على الكريات ريشيو، ده عشان يفرق لي ما بين البرايمري كوزز، ان كانت هي اساسا هايبوكاليميك بريودي باراليسيس ولا هو في بوتاسيوم لو بوتاسيوم نتيجه حاجه تانيه.
مم.
تاني حاجه جينيتك تيست، وفي اي سي جي. طبعا الاي سي جي بعمله عشان
مم.
عشان يكون في اريزميا.
مم.
وايه هي الهايبوكاليميا؟ بتعمل ساينس برادي
مم.
وفلات تي ويف ويو ويف في ليد 2 وفي 2 وفي 3 وفي 4 واي سي تي سيجمنت ديبريشن. كانك شديتي الاي سي جي كده، ساينس برادي وفلات تي ويو ويف واي سي تي ديبريشن.
مم.
اوكي. بعد كده عندي نيرف كوندكشن ستادي واكسرسايز تيست، ان انا يعني اعمل اكسرسايز واشوف بعد الاكسرسايز بيجي له فعلا الايه الاتاك دي ولا لا. التريتمنت بتاعنا اورال بوتاسيوم بيتر ذان اي في، وبديه
مم.
جرعه 0.5 to 1 ملي equivalent per كيلو جرام. يعني لو هي 80 يبقى بدي مثلا 40 80 ملي equivalent.
مم.
بتوين الاتاك بدي حاجه اسمها داي كلوروفيناميد، ده ابروفد للهايبو والهايبر كمان، هايبوكاليميك
داي
بريودك باراليسيس.
كلورو
داي كلوروفيناميد.
فيناميد.
اه داي
آخر
كلوروفيناميد
آخر اي دي اي.
اي دي.
اوكي.
دايكلوروفيناميد ده
Dichlorophene.
ابروف للبوست هايبوكاليميا وهايبركاليميا. بتجيب جرعة 50 to 100 مللي جرام دي اي دي.
IV.
لا ده اورال مش غالي.
بديه 100 ل 150
No 50 لا 50 to 100.
to
50 to
100.
100 دي اي دي.
Oh, okay.
alternatively اسيتازولاميد
Mm,
او بوتاسيوم سبيرنج دايوريتك اللي هو السبيرونلاكتون.
okay.
الدايتيشن طبعا بعمل زي ما انت قلتي ريفيرال للدايتيشن لاني بعمل لو كربوهيدرات ولو صوت لايت. اوكي
Okay.
بس
تمام. Thank you so much. جزاك الله خير.
البيت فيديو ما شاء الله.
Thank you.
Thank you, Dr. Imaz and Dr. Shema for nice case and well performance as usual, Dr. Imaz. Dr. Shema, before you leave, can you tell us about the differential? She gave you the periodic paralysis as a hypokalemic. Yes, tell us, yes.
الديفرنشال دايجنوز فور بريودك باراليسيس هما حاجه من اربعه، اما ثايروتوكسيك بريودك باراليسيس او
Excellent, yes.
او هايبر كاليميك بريودك باراليسيس
Yes,
او هايبوكاليميك بريودك باراليسيس او يكون ده كونفرجن ديس اوردر.
excellent. Yes, this is the one. You're right. So thank you, Dr. Shema, again for the case and well performance, Dr. Rimaz. You will start commenting, then you can receive our comments.
Yeah, please.
Yeah. Okay.
Good evening.
Dr.
I
Daria?
would like to,
Yes.
yes.
Yes, Dr. Daria. Yeah.
I would like
Here
to
you are.
add cataplexy. So we need to ask about any emotions about that, any sleeping disorders as narcolepsy. Cataplexy, one of the symptoms of cataplexy, so sudden loss of power or weakness. It could be another differential you could add on the list.
I'm sorry, can you
Yes.
say this again? يعني أنا هو
Cataplexy.
الديفرنشال
Yes.
الكتابلكسي يكون واحد من الديفرنشالز فأقوم أنا
Yes, you need to ask. Yes. Yeah, any emotion sometimes with laughing, with tense emotion, crying, laughing, you know.
Yeah,
So he might lose his all,
the power.
all power. Yes, or fell down, but consciously. And so you need to ask about that and to ask about sleeping. If you feel
دي كاتابلكسي تبقى كده
cataplexy.
emotions.
Yes.
Yes.
شوفي الفيديوز في يوتيوب very funny and you will never forget them. They laugh and then they just fall on the floor.
Yes,
Yeah.
not only laughing, any intense emotions.
Yeah.
Okay, so intense emotions, ask about that. Ask if it's cataplexy, ask because cataplexy is a part of narcolepsy, so you need to dig more about sleeping disorders. So do you sleep well? Do you have any sleeping problem? Are you sleepy during the day? So this is kind of cataplexy or as a part of narcolepsy. Okay, and then that the other thing that you have. Thank you.
Yes, thank you, Dr. Dalia, for adding this differential, very important one. Yeah, but all body will be like paralyzed. Almost the same of hypokalemic periodic paralysis. All body will be paralyzed. Okay, so I will send the comment, Dr. Rimaz. I actually you become more and systematic and organized manner, mashallah. You didn't miss any system in this case. Okay. The onset course duration, you ask well, previous attacks, the how it started, sudden sensation association, the arms and the legs and distribution in the body, the timing exactly, morning, evening, or what time exactly. And you ask about the association of conscious level. It's great also. This one will rule out cataplexy with the conscious level because the one with cataplexy, he will lose for a moment his awareness. Yeah, and what time For how long it lasts, you ask as well. It's good to know and to put. The only missing point and question in this scenario, what precipitated? And this, as Dr. Shayma said, is very important. What precipitated? However, you ask what before and after, and your friends help you to resolve. Yes, they are helping and supporting, but you didn't ask what you were doing before, because this is the tricky in this scenario. Eating high glucose or high caloric diet, or asking for what exercise they did before or done before. This will exacerbate or precipitate the attack. So you, apart from this, you ask for the trauma, you ask for the back pain, you ask for stress. You miss also the stress. It might be conversion disorder. This is one of the also important differential. So stress this as a precipitating for conversion, it's very important here. Okay, the CNS face shape, you ask nice question to roll out any cranial affection, but the headache, you can put headache as a question in any CNS system review. Sometimes the migraine might come like this scenario, but it will be unilateral, of course. Hemiplegic migraine, I mean. So headache, if you ask it, just roll out, it's not related to migraine. Cardiovascular, you did chest pain, awareness, heartbeat, GI, swallowing difficulty, abdominal pain, yellowish, endocrine, you did also to roll out. It's very important in this patient, endocrine system. For the thyrotoxicosis, periodic paralysis, because this is another differential in our patient. You ask for the weather preferences. Genitourinary, you ask. Skin and joint, you did. Family history, once he said to you, I am adopted doctor, 100% or 99%, you have patient with familial disease, since he said that. Travel history, medical and medication, partner, HIV, casual relationship, you ask. This, the social, the job, the alcohol, smoking, driving, here is very important. You should ask him. Because if the attack comes while he's driving, it might harm his life. This is the only point you miss. The support you did by asking his friend support. Examination, you did the CNS examination perfectly. Tone, power, reflexes, coordination. If coordination, put it always with you. Tone, power, reflex, coordination. The gait as well. Inspection, walking aids, car, back, and fasciculation for lower motor neuron. All these will be negative in this patient because he's in between attacks. Eye examination, vision problem. The heart, it's not that much important. The thyroid, you should, even the thyroid is not symptomatic, you should offer it. Might be subclinical one, and you might have the thyroid swelling in the case. Ending this case by, you ask about the constitution, by the way. Yeah, it was great. The diet, you ask also for the diet, balanced diet. So our differential will be either hypokalemic periodic paralysis or thyrotoxicosis periodic paralysis or hyperkalemic periodic paralysis. The three of them are autosomal dominant, by the way. So it might be your differential. You just add to them conversion disorder if there is stress, and it might be also in the females, especially with the female. Okay, and the last one, Dr. Cataplexy, as Dr. Dalia mentioned. Multiple sclerosis you can add as a duration, but multiple sclerosis, he will have upper motor neuron lesion plus the CNS manifestation of multiple sclerosis. So you did great, Dr. Remaz. If the examiner, I will give you full mark. Yeah.
هي الوقت كمان المالتيبل سكلروز هياخد وقت اطول شويه من كده. الاتاك نفسها مش هتبقى سهله.
What? Yes, multiple sclerosis yeah, lasting more months or maybe weeks. Yeah, and MRI in this patient, Dr. Remaz, to mention, it's overestimating image you do for MRI. If no scar and no multiple sclerosis signs, don't mention it. You have clear case of hypokalemia, hypokalemic periodic paralysis. So you don't go for it. I mean, imaging, which is for this patient not necessary. The hypokalemia, you will analyze it well, or electrolyte you should do. Electrolyte including potassium, phosphorus, magnesium. And while correcting the potassium, by the way, you should estimate the magnesium. Sometimes the resistant hypokalemia related to hypomagnesemia. So you offer checking the magnesium. The next thing to do, the ECG, yes, and the ECG will show you severe hypokalemia or no. The severe hypokalemia will be with ECG change, as Dr. Shema said, prolonged QT and U wave and inverted T. These three changes equal to life saving management of this patient. You will put injection potassium. Definitely, you should give injection potassium. In between attack, and if no ECG change and no symptoms, you can give oral potassium correction. And in between attack, you can add also. Sorry?
وفي الجايد لاينز وفي الجايد لاينز كاتبين ان اورال بوتاسيوم بريفيرد بيتر ذان اي في الا اذا كان فعلا فيها اريثميا يعني شديده يعني.
Yes,
لكن
yes.
هو الاصل
Yeah, but if there is severe
لو مفيش اتاك
hypokalemia, yeah,
حتى لو دي
if
اتاك
no,
ما فيش حاجه بدي اقول
agree. But if there is ECG change, you should give an injection because it will be fast correction and it must be fast correction. But for potassium, for the oral one, it will take time. This is regarding the management, the investigation. You did well. Don't forget the potassium sparing agent, the spironolactone or aldactone. It will help as well. Thanks, Dr. Rimaz and Dr. Shaima for the case. We will receive the comments and we can read the comments. And Dr. Rimaz, share us the YouTube of cataplexy, I guess, Dr. Rimaz. We will see. Is weakness. Let's
I
start
did
from
send
the
it. I
beginning.
did send it. But this is like
Yeah.
this is like a cartoon, but there are videos if you wrote cataplexy patients or cataplexy attacks, you will see
Mhm.
patients once they start laughing, they just fell on the floor. Or if they're crying, they fell on the floor. And then the narcolepsy is that they just sleep. They would be
Yes.
laughing and then they would sleep in the middle of the laugh, which is very, very weird. I don't think anyone will forget it if you watch it in YouTube.
Yes, thank you, Dr. Maz, for this video. You can watch it later. I will send the link to the group, or someone can copy it and send it to receive the other comments.
Okay,
Differential,
where
Dr. Ihda asked for,
where's the video?
sorry, in the chat
Where's the
box,
video?
in the Zoom chat box.
Put it Dr. Mas, please put it in the group.
Okay.
Okay.
Come on. Oh, I thought I sent it in the group. Yeah, I send it now.
You send? Okay.
I send it to my family group, sorry.
It's okay. They will just have some laugh.
Okay.
Okay. Yeah, differential diagnosis, Dr. Ihda asked. Yes. Hypokalemic, hyperkalemic thyrotoxicosis. All of them periodic paralysis. They comes in period like attacks, and in between they are free of attacks. But of course, the difference between them, the hypokalemia, and the thyrotoxicosis will be manifestation of thyrotoxicosis. All of them are autosomal dominant, so they might be familially 50% transferred. Okay, thanks, Doctor. If you have notes or video, please share. Okay, Dr. Hiba asked. Is weakness here bilateral? Is it floppy or stiff? It will be quadri, all limbs, and it will be floppy. Yeah, it's lower motor. It means, I mean the muscles, affecting the muscles. I share the YouTube. Thanks, Dr. Ihda. Okay, if no more comment, no question, we can shift to the next scenario. Any question? Any raising hand? Okay. So, Dr. Imaz, can you write your case? Dr. Hiba, you want to ask?
I did send
Yeah,
my,
just I
I
want
did send the
to
case.
say thanks. Thanks for Dr.
Yeah.
Shaima and Dr. Imas,
Mhm.
because I just was thinking about this case. And Dr. Shaima, please, if you have any notes, please, about the case. And thanks for the nice prescription of the ECG. I think no one will forget
Forget it.
this.
Yeah.
Yeah, very nice. Thank you very much.
Okay, thanks, Dr. Rahiba. Okay, Dr. Shaima, prepare yourself. The case, 40 years, lady
Okay.
presented with vision problem. Okay, I will ask a favor to our colleague not to put the names of Arabic names. Sometimes we have the same
Patient?
name of this. Yeah, so better, yeah, Lisa, Sophia, any foreigner name, I mean.
Sorry, guys.
Okay.
Okay. Sorry.
No, no, it's okay because we have history of fight because of the name of
Oh, really?
the
Okay.
patient.
You can name the
Yeah.
patient Rimaz then. It's okay. Your
No,
patient's name is Rimaz Shema. Okay.
yeah.
Guys, feel
Not
free to
all.
name all your patients Rimaz. I'm totally okay with
No,
it.
no, no. Yeah, yeah, yeah. It's not like that, but the minds of people different.
Yeah,
Sometimes
definitely.
thinking.
Yeah, it's totally
Yeah.
fine.
So make it Lisa or Sophia, or I prefer to put some foreigner names.
Okay.
Okay. Thank you. So it will be Mrs. Lisa. No, 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 not Rimas. We'll make it Lisa. I will repeat the scenario. Mrs. Lisa, 40 years old, to present vision problem.
Okay.
2 ladies, 2 minutes, Dr. Shema, and then we'll start.
Okay,
Here we
we
have,
can start.
yeah, Dr. Shema, please, before starting, someone asked for the oral medication can be given. What I'm sure about aldactone, potassium sparing agent, helping for retaining of potassium in the body. But the medication mentioned by Dr. Shema,
She
I
said
missed the.
dichlorofenamide.
Dichlorofenamide.
Okay, so
Dichlorofenamide is approved by FDA.
okay, if you can write it, please, in the group,
Okay,
would be
I
more
will share the
helpful.
notes, inshallah. Send it
Okay.
I will
Yes,
share
and
the
Dr. Dalia also was asking about the previous scenario. What about the nature of of weakness? Is it proximal or distal? So Dr. Shema can tell us. Yeah, most
both
welcome.
limbs
Okay.
and arms. Both arms and lower
No,
limb.
no. Yeah,
Main
yeah,
limb.
it's the hand
Shoulder.
or the shoulder or like that, or all the same.
All the same. يعني ده بيتقال
Okay,
لما
so
بنقول عليها
mm,
all the same.
so so gross weakness. It's not
Yes.
either. Yeah, it's neither proximal nor distal. Yes, mainly proximal, I think, is writing.
Stop.
Okay. Okay. So let's start our case.
good morning.
Yeah.
Morning.
Fine.
Hi.
Fine. Fine. خلاص. Good morning. I'm
Hello.
Dr. Ibrahim. I'm Dr. Ibrahim, the doctor in the medical OPD today. Nice to meet you. Are you
Hi.
Mrs. Are you Mrs. Sameh, 40 years old?
No, Miss Lisa now. Miss Lisa.
Okay, Mrs. Lisa, 40 years old.
Yes, yes, doctor.
Miss Lisa, today we are here to discuss issue related to your health, and I will examine it. Is okay with you?
Yeah, sure.
Okay, it came to my knowledge that you are complaining of vision problem. Can you please tell me more about this?
Yes, doctor. I just have been having some double vision, and it's really annoying me.
I'm sorry for that. What do you mean by double vision? Do you see double for each object?
I see double, yeah, both eyes.
Both eyes.
Yeah.
Okay. If you cover one eye, is this double vision disappear?
I'm sorry.
If you cover one eye, is this double vision disappear?
No, it doesn't.
No. Okay. When this double vision stop exactly?
When did it start? It's just it comes and goes really. It's not really a thing that happens for like a long period of time, but it happens in periods or something.
Okay, it comes, yeah, it has a diurnal variation. Did you notice anything that bring it?
I was shopping yesterday and I went shopping, grocery shopping and some clothes shopping. And when I went to the grocery shop, it was the last thing. I couldn't move the grocery bag. I just had to kick it. My hands and I couldn't open my eyes and I just started seeing everything double.
Okay, it lasts how long it lasts?
It lasts for hours and hours. I had to sit down on the floor for a while before it goes
Okay,
away.
okay, okay. When did it start for the first time?
About 8 months ago.
8 months. Before this 8 months, it was normal. It was well normal.
No, I never had this before, no.
Okay. During this month, it is how frequent it is?
It happens every I would say if I'm ill, especially if I'm unwell. I had some waterwork infection that made it worse. And then I had some chest infection also made it worse.
Any infection make it worse. Okay. Okay. Did you notice that it increased during at the morning or at the night or after
I
excursion?
think towards the end of the day. In the morning, I would be okay.
At the end of the day. Do you have
Yes.
any? Do you have any? Do you have any difficulty of speech?
No.
Difficulty of swallowing?
No, my swallowing is fine. It's my chewing. I have problem with chewing, not swallowing.
Chewing?
Yeah,
Okay.
like if I'm eating in a restaurant, sometimes I just have to move the food and scoop it, fish it out of my mouth because I just can't chew anymore. I just stop chewing sometimes.
I'm sorry for that. I'm sorry for that. I'm trying to help you. Okay. Do you have any dropping of your eyelid?
Yes, as I said, yeah, doctor, earlier.
Okay. Dropping of eyelid. Okay. Do you have any difficulty breathing?
No.
Change of voice?
No, I didn't notice any change of voice.
Okay. Do you have any difficulty in holding hair or standing from sitting position?
No, normally no, but if I had the attack, yeah.
What? Again, please.
If I have the attack, yes, while I'm having the attack, I find difficult.
Okay. Okay. Sorry for that. Okay. Do you have any racing of heartbeats?
No.
Any headache?
No,
Okay. Mrs. Lisa, do you have any post-medical illness or surgical operation should be aware
no,
of?
no.
Any medication?
I just have an anxiety.
An anxiety. Do you take any medication for anxiety?
anxiety.
Yes, I take some medication for it.
What is medication?
Anxiety
Show me
development.
medication.
I
Show
take
me your medication.
propranolol.
Propranolol. Okay.
Mm.
For how long you take this propranolol?
I just started this medication last week. Sorry, doctor, my voice is just changing now.
I'm sorry. Sorry for that. Last week?
Yes,
Only last week. Before that,
yes,
there was no.
no.
Okay. Any other medication?
No,
You told me that you have chest infection and urinary tract infection, and you take antibiotics for that.
I did take antibiotics, but it's not a thing that I take for a long time. It's just for a week or so.
Can you please tell me? Did you remember the name of this antibiotic?
No,
Before these attacks begin, you start any medication, even antibiotics?
I don't remember, doctor.
Okay. I will ask you some questions. Do you have any weight gain or weight loss?
No,
Do you have any lumps in your body?
no,
Okay. Do you have any tired? You said you have tiredness at the end of the day, yes?
yes,
You have tiredness. Any throwing up? Any throwing up or feeling sick?
no,
Okay. Any fit?
no, doctor. No
Any
fits.
dizziness? Any
No,
dizziness?
no.
You said no headache, yes?
I'm sorry?
No headache. You said
No
no
headache.
headache.
No,
Okay. Any abnormal movement?
no,
Any abnormal sensation?
no.
Any loss of control of bowel of bowel of bowel of bowel? Your bowel?
No, not really.
Okay. Any loss of control in your outer work?
No,
Okay. You have any heart racing?
no,
Any chest pain?
no,
Any lower limb any lower limb swelling?
no.
Any cough?
Sometimes, yes, doctor.
Have cough? Okay. This cough dry
Yeah,
or with
just
phlegm?
dry cough. No, just dry cough.
Okay. This dry cough. Did you notice anything that increase it?
No,
Okay. Okay. Any cough of blood?
no,
Any loose motion?
no, doctor.
Any hard motion?
No,
Any tummy pain?
no,
Okay. Any change in water work?
no,
Okay. Color, amount, frequency?
no,
Any fluid urine?
no.
Do you have any weather preference?
With a preference? No, doctor.
Do you have any weather preference? No. Okay. Do you have any? Do you have any weather preference? No. I'm sorry for that. Do you have any family history with similar condition?
No,
Okay. If any family history, if no,
no.
okay. What about your period? Is it regular?
Um, it's regular, yes.
Okay. Do you have any kids?
Yeah, I have a 20 years old and a 22 years old.
Okay, mashallah. Okay. And the last child the last one has 21 years old. Yes.
20, yeah, 20.
Okay. Do you have any history of miscarriage?
No,
Okay, do you smoke?
I do smoke on and off, yeah.
How many cigarettes per day?
Maybe 3, sometimes 4.
For how long?
On and off over the last 40 years.
Okay. Okay. I need from you to stop smoking, and I can help you by tell you to stop smoking cessation clinic, as it may
Okay.
worsen your condition. Okay.
Yes. Okay.
Do you drink alcohol?
Just occasionally, once a year or something.
Okay.
On Christmas.
Do you drive?
Yes, I do drive.
Please, I want to do from you. We need from you to stop driving until further assessment, as this double vision may affect your safety. Okay. Can I examine you, please?
Yes, doctor.
Okay. What do you do for living, Mrs. Lacy?
I don't work now.
What was you do? What was you doing?
I was a
What did-
teacher.
And now, why you stop
Uh,
work?
because once I finish the first class, I just can't stand up anymore and I can't speak. It's very annoying.
I'm sorry for that, Mrs. Lacy. I will try to help you, and I will write a letter to the traditional health doctors in your work, and I will help you as much as we can. Can I examine you, please?
Yes, doctor.
Okay. I will put my finger above. Please look to my finger and count from 1 to 20.
Okay.
By high voice. 1, 2,
Yes.
4, 5.
Toes is by, yeah, like 15.
Okay. Can you please do like me by shoulder كده abduction 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 abduction, and I
Okay.
will do proximal myopathy sweep, yes,
Okay.
and I will go smile to me, please smile to me.
Normal.
Okay. Can I please open your chest كده to if there is any scar or something? Okay, and I will put my stethoscope to see if there is any problem in the heart. Okay, in chest, brackets. Okay. Any thyroid
Normal.
swelling? Any
No.
thyroid swelling?
No.
Okay. Any lower limb edema? What about the pulse?
Normal.
Okay, H shape. I will examine the vision. H shape. When you see double
Uh,
please.
yes,
Let me
I see double.
Okay, I'm sorry. Okay, visual acuity. First visual acuity, then visual acuity. What's your concern, Mrs. Lacy?
Am I going to be like this doctor forever? It's very frustrating.
I'm sorry for that, Mrs. I will try to help you, and I will. I actually after taking history, and examining you, you most likely have a condition called myasthenia gravis. Don't bother yourself by the name. This is a medical term, medical condition in which there is a problem, a problem in your defense system attacking the junction between muscles and nerve, making these symptoms that you have. And what we need to do now is to admit you and do some investigations. And I will do some investigations in form of blood test and imaging. And I will sit with you again to discuss the management plan. For the time now, I need from you to stop smoking. I need from you to I will need a meeting with your doctor to regarding the propranolol, as this medication may precipitate attack, may sometimes precipitate attack. Although you take it only 1 week ago, but I need to review this medication with the new doctor also, between new doctor and the nerve doctor, and I will sit with you and I need from you to stop smoking and to stop driving.
And my work?
and I will write a letter for your occupational doctor, the health doctor in your ward, and I will give you sick leave until further to solve this problem. Okay.
Yes, thank you.
Okay, time is up.
Nope.
Time is up. Okay, let's. Yeah, you did great, Dr. Shayma. Let's go to the exam time,
Okay.
please.
So what were the findings on this on history and examination?
This patient has the features suggestive of myasthenia gravis in the form of positive integrated test in both arm and eye. Also, she has myasthenic smear, and I couldn't appreciate any feature of pneumoma. المفروض كنت أعمل percussion.
Exactly. Yes.
بعد كده انت قلتي السؤال ايه مش ناس؟
The findings. Okay, so what's your differential?
My first differential myasthenia gravis
Okay.
maybe drug induced, but due to propranolol or some antibiotics she take. But these features appear since 8 months, and the propranolol only for 1 week.
Okay.
So
Lambert-Eaton. What about Lambert-Eaton?
maybe
might
Lambert-Eaton,
Mm.
maybe Lambert-Eaton.
Okay. What's the differential of an eye drop generally in a patient?
Eye drop in general vision, maybe myotonia dystrophica, maybe multiple sclerosis, maybe myasthenia gravis.
Yeah.
double vision myasthenia gravis ممكن تكون graves نفسها. بس ده
Okay.
double vision. drop.
Okay. How would you investigate this patient?
By basic investigation and CBC, renal function, and electrolyte and inflammatory marker. I will do also auto-antibody for myasthenia, which
are the antibodies?
which is anti-specific muscle antibody, anti-specific muscle.
Is that the anti-musk?
Anti-musk antibody.
Okay.
وانتي-acetylcholine receptor antibody.
Yes, perfect.
Anti-acetylcholine receptor
Great.
antibody.
Okay, what else would you investigate for?
I will do also EMG, repeated EMG for the decremental response.
Okay, great.
And repeated nerve conduction study for decremental response. And I will do EMG for the guttering.
For what? I'm sorry.
Guttering.
Okay. And what else?
I will do for associations. It is autoimmune disease. Can be associated with other autoimmune, like diabetes, like thyroid. I can do also for complication. I would like to measure forced vital capacity.
Perfect.
And pulmonary function test. It's not pulmonary function test, forced vital capacity. And if it is affected, I will admit here.
Okay. What's the most associated autoimmune disease with myasthenia gravis? The disease that comes with myasthenia gravis the most?
Pneumonia vulgaris.
Yes, perfect, mashallah. Okay. So the management.
The management, it will be in a multidisciplinary team, non-pharmacological and pharmacological. Non-pharmacological counseling and education and physiotherapy. And pharmacological in acute attack, I will give her pyridostigmine. And also I will give her acute attack IVIG, plasma exchange.
Okay.
And in between attack, pyridostigmine.
Okay, great. Anything else that you want to do?
In the treatment or in investigation?
I think it will. This is gonna be like your full mark if you answer this question. Anything else that you want to do in the management?
In the management?
Mm. Management, I mean treatment and investigation.
I will give her thymectomy. I will maybe need the surgical thymectomy.
Yes,
The
perfect.
indication of thymectomy, if there is autoantibody, or
Yes.
if there is cosmetic, if there is shortness of breath, severe
Yes.
shortness of breath.
Okay, I think time's up. So yeah, I think mashallah tabarakallah, I did very, very well, Dr. Shema, very well. Because mashallah, I have the case written here, and you literally tick all the boxes. I just needed you to say CT scan in the management plan, CT scan of the neck for the thymoma. And in the treatment, so preventative, we do we do the surgery, the refer the patient for thymectomy in 2 cases. Or if we had one of 2, which is the thymoma in a CT scan or positive antibodies like the acetylcholinesterase or something. But otherwise, you did everything, nerve conductive study, and you told me what you need to do. So and how you were organized, mashallah, in putting the general and then specific plots and then looking for complications. You did the thyroid function test. Maybe you can add hemoglobin A1C just to rule out diabetes. CT scan of the neck, as I said, forced vital capacity. Because here it's the diaphragm get affected by the myasthenia gravis as well. We can, I think the only thing I can add is the question I didn't ask you. So differential diagnosis of unilateral ptosis, it can still be myasthenia gravis in the top of the list with Lambert-Eaton coming after that. And then third nerve palsy, Horner syndrome, and botulism. Okay.
The unilateral.
I'm sorry?
The unilateral.
Unilateral, yes.
معلش تاني unilateral. احنا unilateral قلتي أول حاجة خالص هيبقى السيرفر.
We still have myasthenia gravis on the top of the list with and but following it Lambert-Eaton, and then third nerve palsy, Horner syndrome, which obviously Horner syndrome, the one that includes nystagmus and dryness, and then botulism. Okay. And then it says if it's unilateral, then I would say, do I have dryness or no dryness? If there's dryness in all the body, it might be, like the Horner syndrome happening because of I have a stroke or space-occupying lesion or multiple sclerosis. If I have only dryness in the face with the eye drop, it can be Horner. If there is no dryness, that means that it's post-ganglionic, so it happened after the ganglion. So it might be because of the neck, carotid, for example, dissection, or carotid aneurysm, or maybe in the head, like in the form of cluster headache or cavernous sinus thrombosis. So if there is no dryness, cavernous sinus thrombosis, cluster headache, carotid dissection, all of them start with C. Carotid aneurysm. So I think I remember it's STC. So S is dryness all the body, unilateral eye drop or with dryness in all the body, stroke. So that means dryness all the body, space occupying lesion and sclerosis, which is multiple sclerosis. And then dryness in the face, which is gonna be the Horner syndrome. And then there is no dryness, that's the C, which is gonna be the carotid dissection, carotid aneurysm, cluster headache, and cavernous sinus thrombosis.
Sorry, can you repeat that?
Okay. So I have eye drop. Does it come with dryness in all the body? Yes. So it might be stroke. It might be space occupying lesion. It might be sclerosis, like multiple sclerosis. In the face, like Horner. And then if I don't have any dryness, so that would be carotid dissection, carotid aneurysm, cluster headache, and cavernous sinus thrombosis. You asked the patient about the medication. So myasthenia gravis itself can be worsened by the medication. That's why the patient, every time she had the antibiotics, she got worse. This was a real case in the hospital. I saw her on Sunday, which was yesterday. But the patient was like in her 60s, maybe late 50s.
Yeah, she's
And
known to have myasthenia, but worsened by
she's known to have myasthenia, and her myasthenia just got worse by medications. Despite that, they're very keen, but every time she's unwell, she have viral infection. Even if she didn't receive any antibiotics, she still get the attacks. I'm not sure. I think you didn't ask me about how do I do at home, because it would be very important. The patient might need carers. The patient might need alarm. How do you do at home? Who help you with cleaning and cooking and all of these things?
with whom you living also.
I'm sorry.
Mm.
Yeah. But otherwise, I think we did everything. Yeah, perfectly, mashallah.
Thank you.
All right.
Yeah. Okay, thanks, Dr. Rimas, for a nice case. Great and excellent, Dr. Shema. I guess this is first time to practice with us.
No,
But
second time.
second time, you did great, mashallah. Yeah, you did it perfect, actually. From the history and the examination and the education, you did everything in this case. So I will just remind us for the points and what you did, okay? The comment here, the onset course duration, you asked well on and off by covering the eyes as you ask also, it's good question. And you ask question which helped you to reach to diagnosis, diurnal variation at the end of the day. So at the evening time, after frequent exercise, this is the question here can guide you to the case once you suspect. And she told you volunteer as chest infection and UTI, and also you can correlate and you can link with the antibiotics in these attacks of infection. And you ask what improved. She told you when I sit down. And previously, yes, there was previous attacks before, so it's on and off. Direct, you ask for the other eye examination, eyelids. Yeah, there was eyelid dropping. But you can immediately ask for the other CNS. The headache you asked, but it was late little bit, but it's okay. You ask the difficulty of speech. I like these questions. Difficult speech, swallowing affliction, and she give you positive chewing. And the voice character, very nice question because it might be nasal tone. Yeah, nice question. All this question was in target for the case to roll in the myasthenia gravis. Then other system review only to roll out the other systems affected, and you can also ask for the diabetes association, the thyroid. So you did cover all the systems. The rheumatology for difficult to cumbing and standing from sitting position was a good question. The dry cough is not significant here. Cardiovascular, you ask heart racing, chest pain, GI, loose motion, genitourinary, any change in the color. You were very systematic in this case. Endocrine, whether preference was very good question to rule out myasthenia gravis as autoimmune association. Female history, you ask about the period and the kids. The miscarriage, I don't think it's important in this case. It's okay. The skin and joint, you didn't ask. The skin and joint system. It might be the vitiligo, might be, as you said, pemphigus vulgaris as skin rash association. So try also to be in your mind, the skin and joint. The examination, so family history covered well. Travel, you didn't ask, it's okay. Medical history, she give you a history of anxiety with propranolol. Then propranolol, you told him maybe it's okay but it's the same. Yeah, it's affecting, it's exacerbating. One of the exacerbating factor for myasthenia gravis is beta blocker. So it's, yeah, and the antibiotic. Good, you ask about antibiotics, and I will add point here. Once you have antibiotic discover that it might exacerbate the factor or the myasthenia, the disease, immediately advise here, please don't take any antibiotics unless will be prescribed by medical advice or by your GP, because she might have this exacerbation because of antibiotics intake. Once you have something positive, try to, is it affecting the job? If affecting the job, immediately advise here. If not, it's okay, you can skip. HIV, no need in this patient. Allergy also, you can ask about the allergy to any medication because you gonna give her some medication in the future. Okay, smoking, you ask alcohol, driving, very important to give advice here and at the end if you have time. The job as well, good question you ask here, what was your job? Because might be retired or might be left the job because of the intolerance to do the job. Immediately at the same time, you can advise for the support, as Dr. Rimal said. Any support you might need in your life, we can offer you. We are here to help you immediately, because how you are coping with your life activity is very important. How she cope, how she teach her how to do her daily activity with her family is very important. This patient, constitutional symptoms you ask, and examination. While doing examination, I want you just to be more organized because you went up, then down, then up. I will tell you how. When you ask immediate after the examination, you went to the fatigability test. It's okay. You can go to the positive test or target test, but try to get the surrounding I mean, be systematic even in the examination. Look at the patient, around the patient, any oxygen, maybe she has respiratory affection, maybe she's using some walking aid. Maybe there is any surrounding. It can also be positive if you just show the examiner that I catch this. So the look of the patient, and the weight of the patient, how she looks, she ate well, she's underweight, the cachexia, these things little important. Even it's not related to the patient, just to show the exam. If you have time, of course, if you have time. If you don't have time, no need to ask. Go to the target. So your target here is the eye. So you ask about the fatigability test. Then you went down to the shoulder. Can you move the shoulder up and down? So in the same time you ask for the fatigability test, ask for the other vision, because you went down to the shoulder, then you went up again to the eye system. So my advice to be finish all your target one time. You have a complaint of vision, so do all the eye examination once by starting by fatigability or afro, as we know, afro acuity, then field, then reflexes, then fundoscopy. By this order, after you finish, do the fatigability test to check for the eyelid drop. And the double vision, it will be in the H shape, which is in the reflexes. H shape will show you double vision and it will not be collected. Okay, this is for the eye. After finishing the eye, do whatever you will do. Shoulder for box myopathy, you can do. Scar, any trauma in any area in the body, as you did, you will go direct to the thyroid after that. Thyroid will show you if there is association. Then the thymoma itself, percussion, auscultation, as you did. And I guess this is the last step. Then you will be with the examiner. The differential our patient, as Dr. Imad said, and you also, Dr. Sarah said, myasthenia gravis and dystrophy and multiple sclerosis. I put also multiple sclerosis. It might present with this double vision. Graves' disease for eyelid dropping, Horner syndrome, and third nerve palsy. Yeah, you have a lot of differential, but the third nerve palsy, the one surgical one, not the diabetic, the medical, I mean, course, because the surgical one will have double vision and eyelid drop. So this is our case by Dr. Ahmed and Dr. Shema. Any comment or any question? I hope we covered the topic well. Yes, there is also exacerbation, and I forget to mention the medication to exacerbate the condition. I mean, what antibiotics you think, Dr. Shema? You remember?
What antibiotic?
Yeah, exacerbate the myasthenia crisis or myasthenia gravis.
Erythromycin.
Erythromycin, yes.
Erythromycin. هي all antibiotics
Aminoglycosides,
aminoglycosides even
skinolone.
penicillin was safe, but
Yeah,
in some cases برضه of myasthenia gravis reported with penicillin recently. There is antibiotic called ketolite. This is fatal. May lead to this with myasthenia.
again, I didn't hear that.
There is antibiotics called ketolides. Ketolides.
Mhm. Right. I
Erythromycin.
don't know about this antibiotic. Safe, you
May
mean?
lead
It's safe?
no. This may lead to this. Even penicillin,
Okay.
penicillin was safe, but some cases of myasthenia gravis are reported with penicillin.
Yes. Okay, so
Most safe
erythromycin,
and vancomycin
yeah.
and clindamycin and sulfonamide. Most safe, most
Okay.
drug.
Okay, so there is mnemonic called exacerbate, starting by A letter, erythromycin for macrolide, xylocaine for lignocaine for X, A for aminoglycoside, C for ciprofloxacin, quinolone, E electrolyte like magnesium, R for relaxant, skeletal or muscle relaxant, B for beta blocker, exacerbate, A for anti-malaria, quinine or quinine, sorry, and timolol eye drop for T, E for eye drop also called ecothiopate. I will share this page and this medication to the WhatsApp group to be more uh, memorized because it's mnemonic, exacerbate. I will send it to the group. Okay. I like also your answer when you said in acute attack and in between the attack. Always, if you have disease with acute exacerbation and presentation, try to mention in acute and in the chronic. MS, one of them. Any SLE patient. Myasthenia gravis is also one of these. But try to start by ABCD approach. ABCD in acute attack. Don't just go to the pharmacological because when you go to the pharmacological, maybe he will ask you more in the pharmacological and you will miss the time for other important education, for example, or counseling. So ABCD approach. And as you said, in the acute attack, high dose steroid. And this is the pharmacological, I mean. And plasmapheresis, IVIG. In between, start by multidisciplinary team approach. Always start like this. Don't just go to the pharmacological. I know most of them, once he remember the management, he will just jump to the pharmacological because we are afraid not to mention this medication and to get the mark. But actually, the judgment not only for the medication, how to manage this patient in your hospital. Be symptomatic and be systematic. Call the other team concerned to the patient. You will not manage this patient alone. Even if you mention all this medication or all these steps, the examiner will tell you, will you manage this patient by yourself? You will be in trouble. You are not safe, doctor. So what to do? Multidisciplinary team approach. First word in the management. Okay, what are they? Of course, neurology, then the rheumatology, then the immunology, and respiratory. Don't miss this respiratory, very important, this patient. Nephrology, also for plasmapheresis, ophthalmology for the eye and eye problems, GP, specialized nurse. This you can mention in all patient management, specialized nurse and GP, and according to the system need, you will call. Okay, finish the multidisciplinary team approach. Then we'll go to the non-pharmacological and pharmacological. Non-pharmacological education, counseling about the disease complication, how to manage, how to deal with the disease, how, especially the advice about antibiotics, advice for any medication, stress. Sometimes the stress is trigger for this disease, infection itself, how to avoid infection, driving, very important, and the support at home, smoking and alcohol, any social advice you can put in this category. Okay, then go to the pharmacological. Maybe the time will be finished and you get the mark by your answer without mentioning the medication, which can be the nightmare for you. He might ask you other medication and you'll stuck with the medical treatment. Give me other medication for the management. You don't know what he asks. What if he asks you the pyridostigmine dose? I don't know anything about pyridostigmine. I just know remember the name. So not just jumping to the pharmacological management. Okay, let's talk about the pharmacological. As Dr. Shema mentioned, pyridostigmine, and you can add atropine in the same time because there is side effect of pyridostigmine, which is bradycardia. So always mention atropine along with pyridostigmine. This is the pharmacological. You can just add some medication for the complication. And as Dr. Arima has mentioned, the respiratory infection very important here to protect or to manage and investigate and manage by doing forced volume capacity. And he will ask you what the volume, indication for this patient to be in ICU. So there's a question for you, Dr. Shayna. How much the volume capacity admission criteria to ICU in this patient? And myasthenia gravis and GBS, by the way.
I don't remember.
Sorry, you know?
I can't remember.
You don't remember?
أنا
So it's
فاكرة نفسي
20,
عملناها كويس قبل
sorry?
مش فاكرة
20
مش
ml
فاكرة
per
والله
kg. Oh, okay, it's okay. 20 ml per kg. This is indication, yeah, for ICU admission to observe for breathing. Patient might be in respiratory failure in the coming couples of hours and he might need intubation. And this will be one of the ABCD approach. Okay, the same answer in the GBS also affection. 15, yeah, 15 to 20 ml per kg, Dr. Dalia, I remember like this. But accurate number, I'm not sure either 15 or I guess 15 to 20. Let's confirm. Okay. Respiratory therapy is also one of the important team, and salt team will be involved, Dr. Shema. You forget this team, very important. Salt team, swallowing and language therapist. Okay. Dr. Dalia, please confirm the tidal volume or section of the respiration, if you can share with us, or you can speak if you have comment or you have some information about this. Any question, any comment?
دكتور حضرتك بتقول 15 to 20 milli equivalent per kg
No, not ml per kg. Volume, it's volume. Yeah.
ده كده indication لو هو less than كده less than 15 يبقى كده
Yes.
indication for ICU.
Indication for ICU admission. They are doing this test in the ward for any myasthenia gravis patient, especially with acute presentation. And they are observing that if the volume is decreasing, the patient will be shifted to ICU for management. I mean for the possible intubation. Vital capacity less than 20, Dr. Dalia, I read it here. Vital capacity less than 20 ml per kg body weight. Intubation typically required when there is the comment. Intubation typically required when the force volume can fall between 10 to 15. This is for intubation. I mean for the admission to ICU. Impending myasthenia crisis requiring hospital admission and close observation of respiratory and bulbar function in intensive care unit for management when force less than 15. Negative respiratory pressure less than 30. Intubation is recommended for air protection. Again, this is for intubation. I guess also the 20 for the ICU admission. There is also what's called myasthenia dip. When you give steroid, the patient might have exacerbation and worsening of the symptoms, and for this reason, also patient might need observation in the coming hours. There is comment by Dr. Dalia for Horner syndrome, anhidrosis face, neck, and upper chest, stroke for S, sclerosis, S facial occupying lesion, anhidrosis in the face, tumor, pancreas tumor, no anhidrosis at all. For C, carotid dissection, carotid aneurysm, cluster headache. I think this one will be anhidrosis all the body. So the opposite, Dr. Dalia, right? Dr. Dalia hates myasthenia
Hello,
gravis
Dr.
trigger. Yes,
Basim.
yes,
I just put it here for Dr. Imas to edit it for
yes,
us.
yeah,
I didn't remember all the causes, but I like the mnemonic that she mentioned. So I
yeah,
tried to
STC.
write, yes, STC.
Yeah, yeah.
Yeah, so if it is stroke, it will be from, it is central, then it would be anhidrosis for face and upper chest, I guess.
So yeah, I agree. The central for all body, the stroke.
Yes,
Yeah.
yes.
And yeah, and the pre-ganglionic will be for the face. Post-ganglionic, no anhidrosis.
Yeah. What's
Yeah.
wrong
And
here in this list?
in the list you wrote, I
Yes.
guess you redistribute them.
Yeah.
Anhidrosis, the
What the
face, neck,
T? What the T? What the other T?
the T,
Is only
tumor, pancreas, and trauma. Trauma. I
trauma.
remember a case, yes, trauma when you do some cabbage or some surgery in the chest and you hit
Also
the sympathetic
thyroidectomy.
change. Yeah, you hit the
Also T
sympathetic
for
chain.
thyroidectomy.
Thyroidectomy as well, yes. If you hit the
Thyroidectomy.
sympathetic chain in the neck, you might have the Horner syndrome as well. So this is one of the reasons.
Anything
Doctor,
missing here in the list?
no. Yeah, clear.
Okay,
I,
thanks.
I will share the picture of exacerbate just to remind you about the mnemonic of exacerbation factor of myasthenia gravis. I will share it to the WhatsApp group.
Once
Yes,
the
yes.
cavernous sinus thrombosis also. The
Cavernous sinus
three
will
already.
be with the C, right?
Yes.
In the center.
Yes.
Yeah.
Already she wrote carotid artery aneurysm and dissection, cavernous sinus thrombosis,
Yeah.
and cluster headache. 4C.
For C.
Hmm.
Okay. Okay. So if no question, no comment, Dr. Tanya is here for the communication also. Don't leave. Wait, Dr. Tanya. You'll be with
Yes.
us. Yes.
Yes.
Okay. Dr. Tanya and Dr. Abdullah, yes, yes.
Yes,
Dr. Abdullah. Okay. So if no question from all, we can start our communication.
I'll give the case, Dr. Abdullah.
Okay, yeah.
I was
Prepare
looking at the indication.
indication for what? Dr. Abdullah, you can't hear me. Dr. Abdullah. Okay. The thymectomy, I forget to mention in the management. Yeah, one of the last step of management, if failed medical treatment, we can think about, or if there is signs of compression or complication in the chest by thymoma. This is important also.
Assalamu alaikum. The connection made me out. There was
Yeah.
from life in the fast lane. I'm gonna share these points.
Mm.
This is for myasthenia gravis. It didn't mention for FVC. I don't know why.
Uh, Actually, any disease with complication might affect the respiration. You will think in this systematic way. Even it's not mentioned in the guidelines. It's okay. You'll be safe if you mention, and if you not mention, I guess it will harm the mark because the patient will be might. By the way, I'm in ICU. I saw a patient with myasthenia crisis, and she arrested because of respiratory arrest. So it's harming and threatening the life. Patient will be in respiratory arrest and might complicate with the cardiac arrest. And if this happens, the patient might die because of late discovery. So he might be, or he must be in ICU. ABCD, protecting the airway, very important in myasthenia gravis patient, especially in the acute attack. Okay, reason to present into ICU and requiring mechanical ventilation. This by Dr. Abdullah Share. Inability upper airway obstruction, yes. Inability to clear secretion, yeah, because of bulbar affection or pneumonia, post-surgical procedure, including thymectomy, resection, tapering, immunomodulator therapy, pregnancy with disease exacerbation. Management ICU, resuscitation, admit to ICU if vital capacity less than 25 and weak cough not clearing secretions, intubate if indicated, airway protection, fatigue, hypercapnic aspirate failure, physiotherapy. Yes. Thanks,
The
Dr.
life in the
Abdullah, for
fast
sharing.
lane.
Sorry?
This is life in the fast lane. I will share in the group.
Okay, thank you.
Dr. Basim, would you please repeat what is the indication of thymectomy?
If there is compression signs and
there
if
is
the medical management is failed.
لا دكتور كمان في indication تانية اللي هي لو positive auto antibody if there is positive auto antibody if there is thymoma enlargement.
I think this is if there is in the scan thymoma enlargement is there, we are going right. And also, as you told, that if antibody positive, I think even sometimes preventive we are doing. As far as I remember, that if even there is no thymoma in the scan.
Yeah, if there is thymoma, also indication is.
Yeah, even if there is no thymoma, sometimes preventive they are doing. If patient is young, I think less than 50 years, and as you told that they are not responding to medical treatment, that time they are doing this thymectomy. Am I right?
Yes, I'm not sure about the age. I'm not sure. What I remember this, the two indication, and Dr. Shaima also said one. So if there is compression signs, if medical management failed, Dr. Shaima, what you mentioned? Indication, other indication.
Antibody positive.
Antibody positive.
Antibodies. Okay. By the way, there is a test called single fiber AMG, Dr. Shaima. It's very diagnostic. Yeah, single fiber AMG. You didn't mention in the investigation. It's important one.
Single fiber AMG.
Yes, yes.
For that
sensitive.
Yes.
Yeah, I think there is another indication for thymectomy. The age, I think, less than 50. And some said the pregnancy, as they will protect the baby from getting the antibodies. I think someone mentioned this point. Pregnancy is one of the indication of thymectomy.
Okay, excellent. Thanks, Dr. Heba. Yeah, thank you. So the pregnancy, one of the indications to prevent antibodies, and the age, less than 50.
I think that young patient has to be with that onset should be less than 5 years. I mean, even a young patient, it should not be for long time myasthenia gravis. If only less than 5 years and medical treatment is not working, that time even you are not seeing thymoma, yes, you can go for the thymectomy. This is like without thymoma, the scan. We can do
and
younger
thymoma,
patient.
Yeah, thymoma also is an indication if the thymoma is there and there is also compression. So we can connect them
This
in the
one,
group.
Mr. Mashar asked for a nebulizer.
Sorry?
I don't know. Okay.
Okay, maybe, yeah, our discussion, not with us. Okay. We can start with Dr. Sarah, so Dr. Tania and Dr. Abdullah, the communication.
Should I give
Yeah.
you, Dr. Abdullah, the case?
Yes, sure. Okay.
Yes, given in the chat box.
Dr. Abdullah, you can read the scenario loudly,
Yeah.
so we can hear and we'll be on the same page.
So I will talk to the daughter, Miss Shelley, about her father condition. Father had COPD, admitted with the high curb score 5, community acquired pneumonia, severe community acquired pneumonia, died after 48 hours. Missed 1 dose of antibiotic because cannula was dislodged and staff couldn't fix because was busy arranging same patient to
I think
HDU.
some. I think it should be some, arranging some patient.
Arranging some patient to HDU. The name of the father is Mr. John, 60 years. Yeah.
Okay, 10 minutes, Dr. Abdullah, then we'll start.
Okay.
Dr. Tania, this scenario appear again, or just
Yeah,
like
exam. Just no. This is this appeared in which some center recently, 2 to 3 days.
yeah, it's because it's known scenario before.
Yeah, unknown scenario.
Okay, good. Thank you for sharing your fresh cases.
Welcome.
You ready, Dr. Abdullah?
Okay.
Okay.
Okay, start.
Hello. Good evening.
Hello. Good evening.
My name is Almanla. I am one of the medical doctors. May I know I'm speaking to Miss Shelley, the daughter
Yes, doctor.
of Mr. John.
Yes.
And Miss Shelley, I understand that you are the next in kin and the daughter of Mr. John, right?
Yes, doctor.
Okay. So Miss Shelley, actually, I am part of your team taking care of your father, and I want to understand. So this meeting is actually we discuss about your father. What do you know about him?
Yes, doctor. My father, he is admitted here, actually. He's
Yeah,
admitted here for last 2 days
yeah.
because he has some infection in his lungs. Actually, my father already had some problem. He is already known case of disease COPD. So
Mm,
now they are telling there is some kind of infection. So he's admitted for last 2 days. I don't
mm,
know. I want to know
mm.
actually about his condition. They are telling before a few hours that they couldn't find any seat for him. I don't know
Okay.
what's happening.
Actually, a lot of things happened recently, and
What happened?
I'm afraid that there is not good news I am carrying with me.
Yes, doctor. What happened to my father? Is he all right?
Well, your father died. I'm really sorry to carry with me this bad news.
Oh my God. What you are telling, doctor?
Do you need
Are
me
you
to
sure
help
this is my
you?
father?
Yes, your father died, and I'm really sorry for that.
Oh, doctor, how could he died? I know the reason. Because they didn't give him antibiotic, you know.
Mhm.
They were so busy, they were not taking care. You guys killed my father.
I understand you must be very, um, somebody in your position must be very, very, um, uh, very disappointed. And actually, your question is genuine. Let me tell you about why his condition deteriorated, if you allow me.
Yes, doctor, I want to know. I want to know everything.
So, yes, you are right. There was antibiotic, the antibug dose that has been missed. But let me get back. So your father actually had a very serious infection, bug in the chest with a very with bad, severe. I'm sorry for saying that. It was really hard infection, and on top of the condition of the chest that he has a condition called COPD that also leads him to risk of the infections. Are you getting me?
Yes, doctor, I'm getting you.
That all this happened. The infection was really hard, and there was also some the nurses were every staff in the hospital, they do their best, but sometimes during the work some things happen, like uh, delaying doses, and sometimes there was a difficulty of giving the drug inside the blood channels.
Doctor, actually, I think he died because he couldn't get the dose. You know, he couldn't get. You didn't treat him rightly. That's why he died.
Well, let me tell you, Miss Shelley, that that was not the reason that he was died. Actually, I am here to help you with your concern, and if you are concerned that he has some mistake has been done to him, I can help you with arranging to complain about that. But this is not the actual reason. It may be one of the conditions things that has led to him worsening. You getting me? But
Yes.
his condition was severe when he came to us in the critical care, and he needed close observation and also there was usually in these conditions they require close support.
So you are not going to do anything against that staff who missed the dose?
Well, I'm glad that to help you with as a part of our policy in the hospital, I will help you with raising this complaint and writing incident report. Part of the improvement we want to improve in our hospital, the policies, so that we do not repeat anything that may affect the outcomes and the treatments of the patients. Let me help you with that. Is that okay?
Okay, doctor, but I also want to complain. I want the name.
Okay. So this is genuine concern, Miss Shelley. Actually, the problem is that it's not a one person. It's a whole team plan. There is no one person fault at the moment. Okay.
Okay, so you're not going to give me the name, right?
It's not like that. It's about there is a team plans here. Everyone is working together. But you can, through the patient liaison office, I can look for the name for you of the office, and you can put the incident report. But it's not a one-person mistake.
What is this office, doctor? This is your hospital. If I'm complaining, then you guys will tell that this is not your fault. How can I believe you? How can I trust you?
Well, we will arrange a meeting with so there is this office, and also we can arrange a meeting with the seniors and the managers in the hospital, so that they discuss who exactly fault is, and they will review all the documents and notes, and they will see if there is a fault of one person has been done, to even if they may think of punishment, if that is indicated.
Okay.
Is that okay?
Okay, doctor.
But until then, you can raise the incident report that I told you, and I may guide you. I would like to help you totally. Is that okay?
Yes. Okay, doctor.
Miss Shelley, I'm really sorry for your loss, and I want to support you with anything you need.
Thank you, doctor.
With whom your father is he is the is there anybody dependent on him?
No, he was dependent on me.
Okay, so you don't need any support at home.
No, thank you.
And we'll arrange the funeral support for you with any documents you need.
Thank you, doctor.
Okay.
Okay, time is up, Dr. Abdullah. Thank you. We can hear from Dr. Tanya first, then I will comment. Yeah, Dr. Tanya, please.
Yes, Dr. Abdullah, you did great. It's a totally new case. Actually, it's a case came in UAE, 26th of this month, died too. So, like the way it was copied, I just pasted it here. You did it very well, as this is a very new case. So just from the starting, next of kin, you started very well. And I like the way that you break the new bad news at the first stage. I trust in this way, because if going from COPD, pneumonia, then if I'm breaking the news that he died, that will take a time. Maybe you would not get the time for other tasks. So this is also, I feel like this is also my way. If he died, I should tell it at the first moment that he died. Then wait for his reaction. That's a very nice, very best thing you did at the start. I like that. And when I was asking actually that he missed that antibiotic, was this, that's why he died? So at first you told me very firmly that no, this is not the reason that he died. But next sentence you diplomatically that super added and balance it, that maybe that it could be those any effects. Just the not the exact line that it no, it is not the reason, not like that. That you can start with that. Yeah, maybe with the second line that yes, it could be a worsening effect, but there is a very less possibility that with only one dose missing of because already he is suffering for a very bad bug infection with underlying lung disease. So he was deteriorated from before actually. So only one dose of antibiotic missing would not cause him to death. It is very unlikely. But okay, so this is the only one thing I think. And the next thing is that a more sympathy, empathy. Of course, this is a new case. That's why maybe you were busy with making the case in your way. That's why sympathy was a little bit low. But it is okay. At the last moment, I think you remembered, and that's why you was feeling sorry for me. But it was very nice. And then when I was telling that this is their fault, just to let him know that yes, your father was some small line, I think, that your father was precious. I can see that your father was precious for you, and he's also precious for us. So we tried our best, like you said, that all the stuff they did. So, but you need to admit that actually it was an error, give a missing one dose, even if there is any kind of reason. So just to admit that, I highly admit that what is happened regarding your father case of the missing dose, yes, that could not be, less likely this is the cause, but yes, the dose missing, it was really unintentional. At the same time, it is not acceptable also. So yes, we are going to do legally. You mentioned about the incident report. I feel like we could also talk about the next morning morbidity mortality meeting, risk management team. Our staff in charge informed, our consultant in charge informed, the legal information that what you are going to do to let him comfort that yes, we are doing legally some steps, that there was a mistake, we are doing for that, but it is not that this mistake made your father died. So the legal issues, not only incident, the other thing I think that we should mention. And this last one thing, yes, I was asking you that what office You told me about pulse office. When I'm telling you that the pulse, it is in your inside, actually you should tell that this is an independent body. It is not inside the hospital. It is an independent body that they are dealing with all these type of complaints and cases, totally independent, not associated with anything with the hospital. I mean, with our hospital, inside the hospital. So like this is the independent body, you need to inform and make him assured that this is, there will be no partiality. Okay, so this is the thing, and you offered me support. That was good, and I don't know the punishment, the word we should use or not. This is I don't know, but yes, they would search for the cause. What happened? You did it very nicely. Regarding the discharge paper, you also supported me. So it was overall very nice, very well done. Thank you.
Thank you. Thank you so much. Nice case.
Okay. Thanks, Dr. Tanya and Dr. Abdullah. Well done. You want to add something or you want to ask question, Dr. Abdullah, before I talk?
What is the alternative of this punishment word? Like, I usually I feel we need more vocabulary, especially in the stress of exam.
Mm-hmm.
Yes, yes, exactly. Yeah, it's better not to mention it. Just investigation will be done to reach to the bottom of this problem, and according to the result, we will update you. So you will not tell here about punishment or whatever what will happen. Just will update you in another meeting. What about the update of this investigation? Okay, the result of investigation. Okay, let's start from the beginning. Dr. Abdullah, you did great introduction. The next of kin point, nice. What you know, but you didn't ask her about expectation to just to know what she expect. Yeah, but try to put it in your mind. The good thing and the best thing you did here is the breaking bad news way. You were very confident that while telling it, and you gave her the golden silence, and you were clear about the news that her father died. You give her time to absorb and you offer her some support. Then she start to blame you why it happened, and I blame you because you misinterpreted. And this immediately you can answer this concern, or you can tell her, I will address this concern later. Let me explain what happened initially from admission till this point. Okay, then you explain as you said, came with severe infection. You can mention serious one, serious infection, and the bug was very strong in his condition, which is having COPD. This condition is already susceptible for another infection because of the original disease in the lung, and the lung already diseased one. So just to give her a hint about the disease and what happened with this. Then I am again now to address the point of missed antibiotics because she asked it again. You just tell her one missed dose will not harm and will not cause the death. And unintentionally, I'm sorry for that. And intentionally happened, as Dr. Tanya said. And we will try to avoid this in future by doing what's called incidental report. However, it's not affecting the condition of your father, and we did incident report for that. Not that the patient will do incident. No, our team or we are the one did an incident report to investigate about that. Why this happened, and be sure that it's not intentional. And in the scenario written here, if you read the scenario, it was dislodged cannula while shifting the patient. So it might be a reason for you to talk about. It was during transferring your father to the critical unit. So the cannula was dislodged. And also, this is not accepted at all, but we will also investigate for that. Maybe this is the reason for not receiving the antibiotics. And we will do our insert report, and root cause analysis will be involved in this event. Okay, that till this point, it's enough because you have another task, which is I don't know, Dr. Tanya, why I'm not sure if in the exam like this or another. So what's important here, the coroner, Dr. Abdullah. I don't know, Dr. Rimas, Dr. Sorry, Tanya. the coronary, why you didn't mention while discussing this point?
Forgot.
Yeah, so the coronary is important in this patient, and explain this within 48 hours of admission. You should refer this to the coroner. Not refer, the coroner will be involved, but you will tell her about that. So the coroner will manage your file, your father's file. What you mean, doctor? You want to take him? The scenario will be like that. It's a hidden agenda. So you will talk now about the coroner. Coroner is a team concerned to the unexpected or unexplained death in the admission, after the admission, to
Within
investigate
48
more.
hours, no, Dr. Basim? It should be
Sorry?
within 48 hours, the coroner, right? It is, they
Yeah,
told
yeah.
died after 48 hours. That's why
After I didn't really
yes, yes,
wait.
yes, yes. It is written died
After,
after
yeah,
48
after,
hours.
yeah. Okay, sorry,
So
sorry.
within 48, yes, coroner
Yeah,
will
yeah,
be important.
yes. Yeah, so one word I didn't read it well.
Yeah.
Yes, okay. So it's now clear for all. Sorry, Dr. Abdullah, and sorry, Dr. Tanya. Within 48 hours will be coroner. After, so it's the patient condition and it's expected to die due to pneumonia, and the curve here, how much? It's 5. Yeah, 5. So it's severe infection. So the mortality rate is very high for him. So expected to be died in the admission. Again, sorry, Dr. Tanya, you're right. Because I
No.
didn't
If you,
focus about the duration. Yeah.
yeah.
Yeah, it's clear
And
now.
it
Yes.
will be in our brain forever that next time, if within 48
Yes.
hours, we will look. Thanks for
Yes,
raising this
exactly.
issue.
Yeah.
These
Yeah.
things will
Yeah.
make your brain
Always
more
the
sharp.
debate. Yeah, the debate and conflicts will give
Yes,
you the
yes,
sure information. Yes.
yes.
Okay. Let's go back to the complaint, Dr. Abdullah. She asked you for the complaint and the name of the patient. You just tell her, I can't give you the name. We are a team. And if you're insisting, I can guide you to the PALS office, Patient Advice Liaison Office Services. You can file your complaint there, and they will update you about the result later on. Then you went to the support, anyone dependent on your father? Yes, I have, for example, my brother, my mother, whatever, or whosoever. Then offer help for this person. If your family needs support, if your family needs to sit with them to explain, to do support, to call the briefing team. It's very important here to call briefing team to sit with the family and to be supportive in the coming hours because of the shocking news. And then the death certificate, you will offer here, the death certificate will be arranged as soon as possible. And yeah, we are sorry for your loss, our condolences for your family. And we'll try to finish this as soon as possible to proceed for the funeral process. Again, I'm so sorry for your loss. This will be the way to close this scenario. Okay. If like this, Dr. Abdullah, you did great. I missed the point of Corona. That's why I have comments on the Corona. But if no Corona, so you did very well in this scenario. Just offer support more and be sympathetic and empathetic. And the mistake here, the incident report, it's not by us. Sorry, not by the patient family or the patient. Incident report by the doctors or the team. And
I
his complaint is different. Yes.
Yeah. Sorry, the last comment.
The incident report will be raised by the family, by the doctor.
Yeah.
The family will do a complaint. This is, yeah.
Complaint.
Yeah, and root cause analysis also you could add to this scenario as a medical error steps. Okay.
They understand the root cause term. Like, it's maybe not understood for everyone. Root cause analysis.
No root cause analysis team. It's the team concerned for any mistake or medical error in the hospital, and they search more and more about the details of the mistake, and they will be updating the result to the team and according to the concerned person. Okay. It's from the name, root cause analysis. So they analyze the cause of and the root of the cause of the error which happened
Okay.
there. Okay. So if any comment, any question, you can receive, and Dr. Abdullah can write the scenario for us, please. You can write here.
Dr. Basim,
Yes.
the last
Yes.
team name you told, can you just tell me? I don't know about this one. The team name you told to tell
Briefing
to
team.
the family members.
Briefing team.
What
Yeah. Yeah, they
what
are
they're doing?
concerning. Yeah, they are sitting with the family to give some support socially and emotionally because the family will be shocking. They are sitting with them and try to absorb their emotional, the emotional moment
Support.
when the support and when some patient passed away or died. The family, some of them are screaming, or some others are crying, some is collapsing. So they need someone to sit with them and to just support them in these moments.
So how we will
Briefing team.
mention? How I will
Briefing
mention
team.
the team?
Yeah,
I mean
you
the
can
sentence
call.
that. Hmm.
You can call the family and who's dependent on your father, and they will sit with our briefing team to be supporting them in these moments, and we will be a meeting with them to sit with your family to give them this news and to support them as well.
Okay, thank you.
Okay. Yeah, I will write in the chat WhatsApp group also this team. Dr. Dalia, are you there? If you want to add any comments, because your experience with the
Yeah,
UK
I
people.
already sent the message today to Dr. regarding this.
Yeah. Yeah, actually, her comments are always valid because she's
Yeah.
dealing with these people as patients and doctors and culture.
Yes,
And
mashallah.
yeah,
Yeah.
her experience are great. I think she is not there, maybe. No, Dr. Dalia, if you are there, you can add some comments if you want, or let's take the other scenario until Dr. Dalia will share. Yes. You can write in the chat box. Yeah,
Did you write,
briefing
Dr.
team.
Abdullah?
No, still.
Yes, actually, it's a, it's a very easy scenario. I didn't prepare a good one.
No problem.
Okay.
Sometimes easy becomes more hard because we are not practicing the easier ones maybe.
Oh, okay. Just a second.
Okay. Yeah, nice sentence, Dr. Abdullah.
Dr. Basim, I shared it in the group. It's lengthy sentence, actually.
That's okay. I can share it in the page, the page I am sharing.
I'm sorry, can I ask So I'm kind of not experienced in the preparation of cases. Like how, mashallah, guys can prepare something very fresh in the exam, but I don't know like how to correct such scenarios. Like I'm not sure. Um, hello.
Sorry, Dr. Abdul, I was talking while my mic
Oh, yeah.
was
Okay.
mute. Okay. I'm guessing that Dr. Tanya heard the expression from examiner from the candidate who underwent this exam. That's why she's commenting. And by the way, the scenarios are becoming repeatedly now. I guess the scenario was before known scenario, but it was within 48 hours. That's why we are talking about, I was talking about corona. But after 48 hours, this is a different one. That's why the scenario will go in this way. Dr. Tanya, you can read the scenario. You got it, Dr. Abdullah.
Yes,
Dr.
yes,
Abdullah,
to be read, please.
Sorry.
you got what I said.
Yeah. Thank you. But
Yeah.
I mean, it's even the, I mean, the time, the examiner sheet, that's the trick. Examiner sheet, it's not easy to find, right? I'm not sure.
No, I guess also by, especially in the new scenarios, it's just a matter of repeating an old scenario, but in different words or sentences. But
Yeah.
the idea will be same. So the categories of the communication are known.
Yeah.
Medical error, breaking bad news, and talking to angry, procedure,
Yes.
counseling about disease. In this scenario, consider as breaking bad news with the
Yeah.
point of either coroner if less than 48 hours or just supporting to the family if less than or more than 48 hours.
Mm.
So it's a
Yeah.
matter of repetition, yes. Scenarios
Preparation.
are repeated. Yeah,
Thank you so much.
welcome. I'm trying to paste scenario here. So you can read the scenario in the page. I know it's little lengthy and this the writing is small, but I'm trying my best to make it clear. Yeah, okay. Yes, now. The role, doctor, yeah, patient, Mr. Peter Morris, 35 years. Okay, relevant, assume you have the patient, okay, consent scenario. You have asked to see patient family doctor. Patient was found to have essential hypertension 2 years ago. After secondary causes were excluded, ramipril and amlodipine were prescribed. His blood pressure over last 6 months has been very poorly controlled, with the recording of more than 160 over 100. Bereavement team, sorry to, yeah, thank you. Okay, more than 160 over 100. He has not been taking his medication. Recent blood and urine tests were normal. Your task is to discuss with the patient why he's not taking his medication, to emphasize the importance of good blood pressure control and to answer any question you may have. Don't examine, don't take history. Okay.
Okay.
Are you ready, doctor? Yeah. Okay, I will share the timer.
Yes, please.
You can see the timer.
Yes, I can. Hello there. Good afternoon.
Hi, doctor.
This is Dr. Akhtar from today's clinic. So, am I talking with Mr. Peter Morrison?
Yes, I am, doctor.
Okay, Mr. Peter, how do you like me to address you? As Peter or Mr. Morrison?
Yes, Peter.
Peter. Okay. So, Mr. Peter, we are here to discuss about some issues related to your health condition. Is that okay with you?
Yes, sure, doctor.
Okay. So, before proceeding further, may I know how much do you know about your health condition?
Yes, doctor. Actually, I have been referred from my family doctor. I have this blood pressure discovered 2 years ago, and I just don't like these clinics. They are not very helpful. They just keep forcing me take this medication. I don't want to take the medications. They just don't help. They just forcing. I'm not a machine to swallow these medications.
Yes, I highly appreciate your concern, Mr. Peter. I can understand the sufferings you are going through. So, if you allow me, I can talk more about your health condition. Is that okay with you?
Okay, doctor.
So, Mr. Peter, as you know already that you are having this high blood pressure without any cause, without any other causes of the other parts of body is fine, totally okay. But you have this BP is always high. That is we are calling the essential hypertension. Okay, so. As you were telling that you don't like to take the medication, so I think that's why the last 6 months in it comes to my knowledge from the referral letter that your blood pressure is totally uncontrolled, is always on the higher side. But yes, they did some test. The test came normal. So I hope that you know about the test result of yours. Do you know? The test we did.
Yeah, I have been told by this doctor that I have normal tests.
Yeah.
But
we did some.
Yeah,
yes.
I'm not happy with the way. I don't want him the way. I don't know how these doctors working. Why he's giving me this? Why he's like forcing me?
I highly appreciate your concern, Mr. Peter, and I understand how stressful you are, as because of this taking medication at this very young age. I really can understand your situation. But Mr. Peter, as you know, whenever the blood pressure, the pressure inside the vessels are more, so it can affect some other, it can be complicated if it is for longer days. If now, yes, your blood test and your water work test come normal. But Mr. Peter,
Yeah.
I'm sorry to let you know that if it is for long time uncontrolled like the way it is now, it can affect your eyes. There could be a vision problem, and it could affect your kidneys. It could
Yeah.
have the deterioration. Maybe it will fail. Even you can have some problem with your heart itself. It could go for heart attack. Sudden, it can lead to the cardiac. I mean, this heart attack can lead to the endanger your life to death. Are you getting me, Mr. Peter?
Well, I know, doctor. I know that's really hard. That more making me stressed. Now, I have a problem with the way that these medicines. I heard that these are not good medicines. I have
Okay.
a problem. I'm concerned that so I will be with these for whole my life. So, but what is this? So I'm afraid of these medicines.
Mr. Peter, I highly appreciate your concern. It's a very valid concern that once you start any medication for hypertension, as it is not curable, it has to be controlled. You need to take whole lifelong. So it is obviously a burden. But Mr. Peter, it would be very unwise if you are not taking this medication and making it uncontrollable and threatening your life. So that your life is precious to you and to us also.
Oh,
So we
thank you,
want if
doctor. I know,
okay.
I know yeah. I know it's really serious, but can you? So I take two types. I take a ramipril and amlodipine, and
Okay.
I have problems. Actually, I found something bothering me since I started them.
Okay, so you are afraid of the side effects, or
Yeah,
sometimes, yes,
yeah.
please. What is the
So
problem you are facing? Why
I
don't you want to take?
I am married, doctor,
Okay,
and actually it's quite sensitive issue.
yes, please. Tell me, it will be totally confidential, the whole meeting. You can
Yeah.
express to me so that I can help
Um,
you.
well, since I started them, I found a problem with the intimate relationship.
Okay.
Mm.
So, Mr. Peter, I can understand your situation. So, as every medication has benefits, also they have some side effect, like the side effect that you are now facing. So, we can counsel with our treating team, our doctor. He can change your medication to other medication so that you will not face any problem with your intimate relationship. Is that okay with you?
Okay, so that will
Is
not
there
be a problem then.
yes, you will be prescribed some other medication with the same function of controlling your blood pressure, but not with the less side affecting your intimate relationship. Are you getting me?
Okay,
Is there any
okay.
other reason? Is there any other reason you don't
So
want to take?
so these are not the same medications, maybe, right? Yeah. Uh,
This yes.
Actually, I am very busy in my work also, doctor.
Okay,
So
so you're forgetting.
yeah, that exactly. I am really busy. I forget a lot to take these
So
regularly. It's really hard.
yeah, I can understand. So let us talk with our treating team. Maybe they will help with maybe instead of two, they can give you one combined dose. And
Okay.
secondly, what you can do nowadays, as all of us are digitalized, you can just download reminder apps in your mobile so that it would help you to remind to take the medication at time.
Okay, that sounds good. Yeah.
Okay, or even if there is someone in your family member that can remind you, whatever convenient to you, to make you remember to take the pills at time.
Yeah.
Is that okay?
Yeah. Actually, my family is cooperative. Oh, thank you, doctor. Yeah. Okay.
Okay.
But please, the frequency is very important to change. Maybe it's easier.
Okay, so we
Yeah.
will try, our treating team will try to do with a combination and also with less frequent one, maybe with high dose, and
Yeah.
also we'll try to have with less side effect. Actually, what is the most main complaint with your problem? The side effect will be less. We will try in that way. Is that
Okay.
okay with you?
Yes.
Okay. Is there any other concern, Mr. Peter?
Oh, thank you, doctor. No.
Okay. So may I ask you some question? Some
Yeah.
personal question. So
Sure.
what do you do for your living?
Oh, I'm businessman.
So does this affect your job? I mean, your business?
No. At the moment, I'm just having headaches. I'm fine.
Okay. So if we start to take that medication regularly, I hope this headache will also not be there.
Yeah,
So
thank
do you
you.
smoke?
No.
Do you drink
Not even
alcohol?
alcohol. No. Thank you, doctor.
Oh, very good. Very appreciated. So, Mr. Peter, I'm going to give you some brochure, and some website also about this hypertension and the complication. Okay. And if you feel any kind of problem like pacing of your heart, any problem with your water works, any problem with your vision, please immediately report us and come to us. Okay. And I'm giving you the number of us. If any query or worry, just feel free to contact us. Is that okay?
Yeah. Thank you,
Okay,
doctor.
thank you. Thank you,
Thank you so
Mr.
much. I'm glad. Thank you.
Okay, time is up. Yeah, let's hear the comment from Dr. Abdullah, then I will.
Yeah, well done, very well done. The good introduction. So the first 6 minutes, I was afraid that you're gonna lose your time, but it should that you discovered my concern initially, that what is the reason that I'm not taking the medicines, and so the patient repeated that, like, I don't know, 3 times or 2. I'm not, so that my medicines is the problem. I'm afraid of the medicine. So he understand the hypertension, and it's good you explained from the disease point of view, but it's the knowledge or expectation initially would save your time. So from that point, he will tell you the problem of the medications. And also, you gave too much information together initially, so that he was like worried. So to balance the worry, that he needs to check the understanding with that slowly, and it needs empathy also to balance with the empathy. He doesn't want the knowledge, just small pieces of information. Yeah, but you did very good. You discovered everything. Yeah. Safety netting and brochures. Yeah. Yeah. Very good. Very well done, Dr. Tanya.
Thank you. Thank
Okay,
you. I
okay,
think that was
thank
also
you.
that importance of taking the medication. That's why that I was doing that task. Then I was going for why you are not taking. But yes, you are right. Thank you. Thank you.
No worry.
Okay, thank you, Dr. Abdullah, for the case.
Thank you.
What you are saying is old case. It's for me, it's like old new. Yeah, you did some
Yeah, this is new.
change.
Seriously, this is the
Yes.
first time.
No, really.
Yeah, it's new.
For me, it's new.
No,
For me, it's new.
what I expected in the scenario of hypertension delayed diagnosis. You know that scenario, Dr. Tanya. Delayed diagnosis of hypertension. You know that case?
That one
If you
also.
don't
Maybe
know, it's
medical error. No, that one also.
yeah, it's yeah. It sounds like medical error. His GP didn't diagnose him, and he came to the hospital to further investigation and diagnosis. And
Pheochromocytoma.
excellent, yeah, yeah.
Yeah,
He
yeah,
stayed
that one
a
I
long
know, yes.
time. Yeah, yes. So little mistake from the GP that he didn't diagnose, and he didn't refer at the same time. So yeah, it sounds as medical error. Okay, let's talk about this patient uncertainty. Yes, uncertainty, not medical error, but we had discussed about this, Dr. Daria. It was like why his GP didn't. Yes, there is some similarity between disease, but he should refer him earlier to further workup. Okay, let's talk about this case. Dr. Tanya, I will comment the introduction, the invitation might need to ask about the invitation if you want to add, call someone to help you, support you. But it's okay. It's if like this confidential issue, it's okay not to mention because he has some confidential issue. The expectation, I don't know why you are not asking about expectation, guys. It's important in this. You didn't ask him. And
Yes.
yeah, explanation of the disease. You did explanation more, and you have one jargon, which is vessels. Vessels, blood channel, I mean, you should mention it will
Mhm.
affect your blood channel being under pressure or high pressure. It will harm the eye, the kidneys, and the heart attack. I like when you said it will endanger your life if you have a heart attack or a heart attack. It might create your life. So this is the seriousness of the condition. You should give him some seriousness in order to convince him to take his medication on time. Directly, you can go to the cause why you are not compliant to the medication. He will mention to you that doctor, I am having problem with alarming. As he said, I'm busy in the job, in the work. I can't, no one reminding. So you offer him the solution immediately. The application in the phone, alarm in the phone, and when he give you another concern, which is a lot of medication, you give a nice solution for that. We might ask your doctor to make it as combination, and it can be taken as one tablet or one time instead of taking a lot of medicine. Yeah, this is nice solution for this concern. The other concern, when he told you something confidential or secret, and you reassure him this will be confidential, it's nice one. However, I don't think the amlodipine is causing that. The amlodipine and the other medication, I'm not sure what it was, but amlodipine is not causing impotence or erectile dysfunction. It's the beta blocker. However, you
Can
address
I
this
comment?
concern. Yeah.
Yeah,
Sorry.
I'm sorry for interruption. It was made that the patient doesn't. He was taken before a medication and then replaced to amlodipine, so he doesn't remember. So he mixed
Okay.
up the doses and now afraid of even these drugs. He was
Okay.
taking maybe alpha blocker before, maybe. So that was the
Yeah.
scenario.
Yeah. Okay. Okay. So, yeah, you reassure him by referring you to your heart doctor to find another alternative medicine. It might help you in this. This is regarding this point, and I like the way you ask him about this because if you ask what you are complaining of, it will be like history taking. So you ask him what's your problem, and you can tell me what's why you don't want to take the medication, just to escape from being taking history. The alarm we mentioned, the family, yes, combined medication. This is your solution, and this is your weapons used in this scenario. The smoking, the alcohol, the job, and support at the end if he needs support. Yeah, this is our case scenario. This and it was a great performance by Dr. Tanya. We can receive a comment or any question.
Can I
Yeah,
ask
thank you.
in my case that was the first I always mix up do I need to invite like so
Yeah,
I did the
so
question I didn't feel
yeah,
safe to ask that question.
yeah. So in this scenario, you can invite and other scenarios, if doesn't contain any confidentiality or something embarrassing to the patient or genetic disease might be known to the other family and the patient doesn't want anyone to know about, you'll not invite. Any breaking
Yeah.
bad news, yeah.
Yeah, it
Any
was breaking bad
breaking
news, very
news.
bad. Father died. So it's
Yeah,
better
the
in that
previous
case
scenario,
to
yes.
invite, right?
Yeah,
Yeah.
yeah, yeah.
Yeah,
Because
yeah.
already the father died. What you think about confidentiality? Already
Family
he's
should
dead.
go. Yeah.
Yeah, no more confidentiality. He did
Yeah.
already.
Okay.
And yeah, if the father is awake and you don't want to break the confidentiality, don't invite. You in this case you will assume that you have permission from from the father. So this is what you will do.
Yeah.
Okay, what else? Any question? Okay, if let's see the comments in the chat box. The bereavement team. Thank you, Dr. Sarah, for correcting the team name. Dr. Abdullah, yeah, Dr. Dalia giving you golden advice. With practice attending free sessions and groups, you find all are similar in the concepts, just different scenarios. Yes, just changing the names, changing the hidden agenda in some cases, changing the complication. But in general, the scenarios are repeated. Uncertainty, not medical error, is written in scenario. You mean the pheochromocytoma, Dr. Dalia?
I think yes. That time she
Yes,
wrote that.
the
Yeah.
blood pressure,
He,
yeah, delayed diagnosis.
yeah, what we discussed before, that if long time and the GP didn't do the all investigation related to hypertension and still the patient is hypertensive, it could be like he's delayed the diagnosis. Why he didn't refer him if the patient still not find the cause of his hypertension. So at least, if not medical error to make an incident report, but at least to be sorry for his suffer. This was a long discussion, if you remember, with Dr. Hind and the point of why he didn't refer, and you can chat with your GP why he didn't refer you to us, why he didn't have some other investigation, if you remember this discussion. So for me, I will do like that. It's not
Okay.
medical error in the hospital, but I will just be sorry for his suffer, and I will refer him to have a chat with his GP why he didn't do the further investigation, or why he didn't refer him to the hospital, to be more clear about the situations. I don't know what happened there, because the patient himself is telling to me, why, doctor, I want to complain against that. I had suffered a lot and without diagnosis. So I should address this point by saying that. So this is what I remember,
Um,
Dr. Dalia. If you have another
yes,
point or opinion,
yeah,
yes,
I
please.
want to comment on your
Yeah.
the plan that you want to do. It's
Mhm.
like uncertainty. It doesn't like a medical error. So if you would like to check that with the GP and to ask him to check that, this is uncertainty here. So
Yeah, still
whether
uncertainty.
you have
I can't
a
say
step
it's.
back to look for the how things it went. I have asked you because if there is usually if it's uncertainty, it's the disease, it's more than 6 months, the GP might have explanation for that. For example, he has checked that for many times that the blood pressure only high during the clinic. There is many,
Yeah.
there is many
White
things
coat
could
syndrome,
be
you mean?
clarified
Yeah.
by the GP. So we need, you could say that this is not our usual practice to delay the diagnosis. Our aim that it's to help you to get the diagnosis and to get your medication. So this is usually is not our practice. So we need
Mhm.
to check that. We'll take it seriously. I will check that with the GP, and we'll revise what had happened and to clarify more about why this take long time to be not diagnosed yet. So we'll
Yes.
see that. And even if you remember the guidelines of treatment of hypertension, that step by step, now the treatment of hypertension is with GP. So the first line is to give, for example, it depends of the age and ethnicity of the patient. Then one treatment, then two treatment, then after three treatment. Then after that, you refer the patient and you will check the treatment, for example, with endocrinology. So refer the patient for investigation. So this is, if you remember the guidelines of treatment. So not all the patients from the start, you start to give, to do, for example, all the investigation. There is some exceptions about that. And there is guidelines for the GPs in their screens. So what to do, and there is guidelines, there is pathway. So
Step by
why
step,
this patient? Why this patient? We don't know. So unless it's written in the scenario that the GB like is negligent or something, and
or reluctant.
something written in the scenario indicative that this is a medical error, I will go straight away to do medical error. If I'm not sure, I will put all the possibilities and the options for the patient, and I will discuss that. Okay, we need to check that. I will take it seriously. This to make sure his concern is valid, and it's I will take care of his concern. Okay, I will take this seriously. I will check that with the GB. We will to clarify what that happened, that you are not diagnosed for a long time, no referral for investigation. Could you give any information regarding that? And you will, if there is any problem, you could ask your GB, and if you need to, because there is if there is medical error in the hospital, so I guess it's inside the hospital, the pulse, but in the GB there is other system for complaint.
GP surgery,
yes. So it's better to be more empathetic. I'm sorry for your suffering. It sounds, you are suffer a lot, and I can see how you feel, and how you are angry, or anything. Then acknowledge that, empathetic with him. So from here, that plan is take him, distract him about that, give the concern, it's not overlook his concern, give him this information, then move to the next step, not push him to do complaint. Okay, so move to the next step. Could I tell you what's our plan of management so far? Then after that, you could say, we will put you on follow-up, we'll do this investigation, we need to do. And then after that, if he's okay, it's fine, and okay, it's not, he's still insisting to complain, I'm sorry to be to be in this situation, but we will, you have a right to do so. I will check that, and even if you don't want to do this, you could go straight away to do your complaint, formal complaint, and then it's something, it depends on the scenario, how it's going.
There is a manager, no, Dr. Dalia, that we can direct him, that with the G, I forget the name, that we can direct him if he insists to do that complaint, then we can direct him to, I don't know what's
patient advice liaison service.
No,
patient,
that is
GP
that is
surgery.
different. For GP,
surgery.
GP surgery,
GP surgery, yes.
We can direct him to GP surgery. If he has any complaint, I think he can do over there, right?
Yes, because different system.
It's clear now, Dr. Dalia. Thank you. So it's not medical error, it's just uncertainty, unless there is clear word in the scenario that there is delayed by the GP. Other than this,
I also heard you one day, you are mentioning that, you mentioned that it's all bed source is a medical error. It's more
If
than
the,
90% is medical
yeah,
errors.
yeah,
But there is sometimes there is inevitable bed sores. Even if with everything, you're with treatment, with
precautions, yeah,
movement, everything,
yeah,
inevitable.
but still can happen,
So
yeah.
it still can happen. So usually it depends on the scenario. Okay. So just look at the scenario. If it's written that it's medical error in any way, yeah, go straight away and say medical error. And if it's something like ambiguous thing, it's bed sores and so and so and so and so, I will, yeah, say the same things for uncertainty, that it's really appreciate, acknowledge, and do that, and say you are sorry, not apologize. The difference is very minor. There is no incident report in uncertainty. You need to go and check with, the scene, the nursing chart, it depends on how the system in the hospital. So in this nursing chart, you will look for that, and you'll investigate. We'll see how that happened, because this is an unusual practice here in the hospital. By the way, there is a tool with each patient, with every admission, there is like assessment. Assessment, like for the risk, even if the patient has nothing, just there is assessment. Every patient, even if mobile, they will do list for his risk factor. There is something like assessment score or something. They put tick on that. I can't remember all the details of it, but I saw it every time. I see it every time with the patient notes. There is assessment for the risk factor. So every patient will be assessed for risk factor of bed sores, or called pressure sores. So this is one to minimize the risk, and there is some measurement to do that, and prophylactic measures will be applied. Many things. So this is the usual practice in hospital. So if this happened, so we'll check that why this happened. We'll check that. We'll take it seriously, and this is not our usual practice here. Okay. So I will come back I will update you about what had happened and so on, like that. Okay.
Yeah, I agree with
Okay.
you, Dr. Dalia, in this
Okay.
point,
Okay.
especially if the bed sores happened recently in the hospital. But if the family or the patient, the family brought the patient with bed sores or even abrasion, and just it persists in the hospital, so it's not an error, because he's already
Yes.
having this bed sores from the start or previously before the admission. This will be
Yes.
like that. Okay. Yeah, I agree with you. Okay, thank
Okay.
you for more
Okay. Thanks.
clarification, Dr. Dania. Always you
Okay.
are helping us with your experience, and I think everything clear in today's session. Any question, any comment?
Hi guys, I just have one
Yeah.
comment. Because I wasn't there the whole time. Tanya, you
Mm.
did very well. I think there is one sentence that I hear people sometimes say. You definitely need to avoid this. And I hate the examiner hates this sentence. It's I understand how you feel, or I understand your irritation. Just try to can see how you can see you struggling. I can see you frustrated, or I see that you're better. So always because
Dr. Naz,
Your
yeah,
voice is breaking.
your voice, yeah, when you
oh,
mention the sentence, your
it's
voice
still
become
breaking now.
interrupted. Yeah, still.
Yes.
Okay.
Please, it's precious
Oh,
advice.
is it still
Try
working?
to repeat it. Yeah, we can't hear clear. Yes, please. Again, repeat from the
Okay.
sentence. What? Yes, again.
So always I do
No, still.
have
It's not clear, Dr. Ranimas. There is some interruption.
is it
Can
okay?
you write it, Doctor?
Yeah, please write it down. I want to know.
Yeah,
Okay.
me too. So
Okay.
excited to know.
Okay, I will write it down.
No, it's clear now. Please say
Oh,
it.
is it? Okay.
Now clear.
All right. So it's very important to avoid this because so I understand how you're feeling. I understand that you are frustrated, or I understand that you're in pain. Always avoid it. Because the patient might just say, how can you understand how I feel? You don't have cancer.
Yeah.
How can you understand how I feel? You're not going through the same thing. And it can be they can actually minus you, as Dr. Salah would say. They can give you minus marks because of building rapport and in clinical communication skills. You can say, as I said, you can say, I can see that you are frustrated. I can see that you are in pain. I can see that you're worried. Just
Yeah.
avoid saying, I understand, please, guys.
Okay.
Yeah.
Thank you.
Yeah.
Thank you.
Thank you,
And I
Dr.
think
Imad.
if when you come here and try to practice this, if you're talking to a patient or a relative and you say that I understand that you're in pain, that can be a very big issue. They might just leave everything and say, how can you understand my pain?
Yeah.
He's not your wife.
Mm.
This is not your wife who's dying.
Yeah. Yeah,
So
you're right.
just avoid
Yes.
it. Yeah. Thank you.
Makes sense. Thank you, dear.
Yeah. Yeah, it makes sense. Yes. So, yeah, avoid, understand, and you can say, I see, or I feel. It's
Oh, you
okay, I feel, Dr.
appreciate.
Imad.
Yeah.
Yeah.
Yes.
Okay.
Yeah.
So not to understand his feeling because you are not in his place. Yeah. So that's
Exactly.
why,
Yeah.
yeah, it will not be accepted by the patient or surrogate and the examiner as well. Okay,
Yes.
Dr.
Yeah.
Rimaz, what about as I told you and as I mentioned to you, as
I
I
think
said to you?
as I mentioned, might be if you actually mention this 2 times or 3 times, you can say, but as I told you, avoid it because it's not for told you is not formal. You can say, as you have been advised, for example, if the patient was already informed or was already
Mhm.
given this information before, but always try to avoid it. There is no need really because the patient knows that you already said that and the examiner knows,
Yeah.
so you don't need to have to say,
Yeah.
as I told you.
Yeah.
Maybe if you
Don't
feel that
irritate
the
him.
patient is actually repeating the same question or ignoring the information, maybe you can say, as I previously advised, but just always try to avoid it.
Okay. Yeah. Great. Thanks, Dr. Rimaz.
Yeah,
Yeah,
I
always give us
comment.
the golden advice. Sorry, yes, Dr.
Yeah,
Dan.
yeah, I want to comment about as I told you, it's not like decent and not polite. So it's better
Yeah,
to say,
yeah.
as we discussed, yeah, as we discussed. This is the best way. Try to say, yeah, plural, like we, us, something like that. It's more, like a more
Mhm.
rapport
Acceptable,
between you
yes.
and the patient, and gives the examiner that the teamwork, and you are engaged in the conversation with the patient. So
Yeah.
as we discussed, okay, something like that.
Mhm.
And I agree with that. And I feel that like overseas examiner are
Yeah.
really weird, and even the sometimes they put something like this, I understand and I understand. It's no nothing. It's like I don't know how to say
Mhm.
it in English. My doctor must help me. But it's like not literally, yeah. I mean, it's sometimes you feel like the word, it doesn't mean that like understand. It's sometimes you feel like I can see it seems like I saw many doctors here using it. So I didn't feel in UK it's a big issue. But if you have sorry for that, Sudanese, Egyptian, Pakistani, Indian, Asian, so not an British examiner, yeah, it's better to avoid things like that because I don't know why
Mhm.
they are
Okay.
very,
Yeah.
irritated
Mm.
by something. It's very
Yeah.
simple. Why you overlook all the performance and just pick this word?
Yes.
So with
Yeah.
overseas examiner, take care. I don't know how is their psychology, but with overseas examiner, take care.
Okay, yeah, this is the
Yes.
most important thing, just to pass. We don't care about them and their attitude or behavior. Just let them pass, please. We want to pass this exam. Whatever you accept or you don't accept what we are saying. Thank you, Dr. Dalia and
Yes.
Dr. Naz, for precious advice. Any advices or any comments before shall we end this session? If no more comments,
Thank you, Dr. Basim, for your effort.
thank
Thank you.
you. Thank you, Dr. Dalia. Thanks a lot. Okay, I will stop recording. Thank you all.